Sorry, Eric, I pushed the wrong button. Try to get my chat and I hit the record button. All right, everyone, we're gonna get started this morning. I wanna thank everyone for joining us. My name is Heather Tebenhoff and I am the Director of Community Engagement for AIM at Melanoma. And this morning we have our symposium with UPMC and I'm so happy to have all of you here with us. Before we get started, just a couple of notes. If you're joining us from Zoom, you can put your questions into the Q&A feature for our panelists. We'll see them there. And if you're on Facebook, leave a question in the comments and we'll make sure they get over to our panelists on Zoom. You can also utilize the chat feature. Let us know where you're watching from this morning. And then this symposium is being recorded, so the video will be available after the event. So if you miss anything, come in late, we will have those available probably within 2 weeks, available on our YouTube channel. We'll also be sending out a survey after the symposium, so please take the time to answer the survey questions that lets us know what sort of topics you're looking to hear at our next events. So without any further ado, I'm going to hand it over to Dr. Kirkwood to get us started this morning.
Thank you, Heather, and thank you all of our patients and supporters and family caregivers who've joined today. We're already at 70 of the registered 150 folk who've joined. And I think we hoped we might be in person at Hillman again, but this pandemic hasn't cooperated. And I think with an inch of snow that unexpectedly dropped on us this morning, we're all probably happy to be doing this by Zoom yet one more time. As Heather said, this is really an educational effort that is fundamental to the effort we've undertaken over the years. Many people think of academic medical centers as places to teach fellows and residents and medical students, but most important of all is teaching our patients and their caregivers and families about this disease that we all have decided to attack and hopefully overtake, that we know of as melanoma. And so I'm really delighted for the participants today, and I should mention to the attendees that we've selected several of the talks specifically in response to queries from participants in last year's session. We do hope that in 2023 we'll be back in person, but invite you to ask any questions you have either through the Q&A or through the chat function, and we will try to answer those at the end of each of the sessions that we have planned for you today. Eric, can I ask whether we've gotten Darcy Kitcha on or not?
Yeah. She's going to try to connect through her iPad, and then I'll run the presentation for her.
Perfect.
So she should be connecting. She should be connecting right now.
Perfect. In that case, we'll proceed with the program as we'd originally planned, but even after 2 years, we have glitches with Zoom and all of the web-based platforms we're using, and so the unexpected has expectedly occurred. And so Darcy has had some problem connecting, but her topic, which is nutrition for patients and their families in relation to the effect of nutrition on melanoma. And we all know what you eat, but I think we'll hear about this from a couple of vantages today. One, the nutritional aspect that Darcy will talk about initially. The second, from Dr. Devar, who will talk about the microbiome, the bugs that are in our guts, which are vastly larger in number than our own cells in our bodies. If Darcy has connected, Eric,
Darcy is connected, John.
Good morning. So sorry about that, having some technical difficulty.
Nutrition.
All right, so I had to send my slide deck to Eric, so he is going to share that for me because I wasn't able to open that from my iPad because my PC wasn't working. So again, I apologize, everyone. So If those of you who don't know me, my name is Darcy Plaucha. I'm one of the PAs with Dr. Kirkwood's team. I focus on the patients on our clinical trials, which there are many. So I help manage the patients on the trials, side effects, etc., with the help of the other PAs and the docs on our team. Today, I'm going to talk a little bit about nutrition and melanoma. So nutrition is such a broad subject, and I only have 10 minutes. So what I did was I narrowed it down to electrolytes. So that's what we are going to focus on today. I know last year when Melissa gave her nutrition talk, she focused a lot on the microbiome, which is also super important. But I just wanted to kind of touch on the electrolytes. You know, we always talk to the patients about, oh, this is low, that's low, we're going to replace this. And so I wanted to go over why that matters and also talk about some natural foods that can help, because I do get that question a lot. All right, so starting off, we're going to talk about, like you said, the electrolytes. So what exactly are electrolytes and what do they do for us? So just a broad definition, electrolytes are minerals that are found in your blood and your body tissues. Important thing about them is they have an electrical charge. And so that helps, as you can see on the slide, move nutrients into cells and move waste out of cells. So those electrical charges are important in the movement of nutrients in and out of the body. They also help balance our water and make sure that nerves, muscles like the heart and also the brain are working properly. So without those, we would have when those are low, all those functions aren't working properly, and it can be, it can, as we'll see here, cause a lot of side effects. Okay, go ahead, you can go to the next slide. So just a little bit about sodium and potassium. I put them together on this slide because they really do work together. And as you can see, they kind of have opposite effects. So the main role of potassium is going to be to help maintain fluid levels inside of our cells. Also is responsible for our muscles contracting and supporting normal blood pressure. And oppositely, the sodium is helpful or is responsible for maintaining normal fluid levels outside of the cells. So these work closely together and they both have effects on the blood pressure. So as you can see on the bottom there, high salt intake, as many people know, does increase blood pressure. But I think something a lot of people don't realize is that high potassium intake can relax the blood vessels and excrete sodium, so get rid of that sodium, which then can lower the blood pressure. So that can be important for patients that are having issues with blood pressure. I am going to talk more about potassium coming up here, as well as some of the other electrolytes. I left sodium for last, and it's going to be brief because there are a lot of different issues involving sodium. So that's a whole nother lecture in itself. So we may get back to that if we have time. Go ahead to the next slide. So what is low potassium? You may hear the technical medical term for that is hypokalemia, so low potassium. We do see that commonly with GI losses. So that would be vomiting and diarrhea, something we always think about if patients are not keeping food down. So symptoms of low potassium. And this is kind of the basis of my talk today, is going to be symptoms and food to manage. So muscle weakness, muscle cramping. I think a lot of patients are aware of that, but it can also cause fatigue, constipation, and then those cramping can include respiratory and GI muscles. So that can make it more difficult to breathe or have, in addition to constipation, having GI cramping. The thing that as a medical provider, I worry the most about with low potassium is going to be cardiac arrhythmia. So that means when your heart is not beating normally, as well as EKG abnormalities. So we can see something called some T-wave changes and things like that. They can indicate that the heart's not working properly. So patients with super low potassium, below 2 or below 2, even below 3 sometimes, or below 3, we will definitely be wanting to get an EKG to make sure you're not having any changes there. Low potassium also affects the kidneys. So it can decrease your phosphate reabsorption, which in the kidneys are responsible for keeping that phosphate in the bloodstream. And so if you have a low potassium, that can lead to a low phosphorus. We will talk about phosphorus a little bit more coming up here because I do see that pretty commonly with our immunotherapies. And then another, I think, lesser known side effect of low potassium would be reducing insulin secretion. So your body's releasing less insulin, which leads to higher glucose levels. So that's something else we may be looking at for you guys. Go ahead to the next slide. So here's my little chart I found on ePain-Assist. It has potassium-rich foods. Everybody, I think, knows about bananas, but as you can see, there are plenty of other foods that are high in potassium that we can supplement our diets with. Sweet potatoes is a really good one. And just fruits and veggies like broccoli, bananas. We can see it with salmon and even coconut water. I know some of our patients are like to drink that, so that can help as well. Go to the next slide. So next we'll talk about the phosphorus, like I said. So phosphorus is the second most abundant mineral in the body after calcium. 85% is stored in the bones and the teeth. So phosphorus's responsibility in your body is to filter out waste in the kidneys and also plays a role in how your body stores and uses energy. Little known fact, it can also help reduce muscle pain after a workout. Go ahead to the next slide. So low phosphorus is a nice long word, hypophosphatemia. So that can be caused or worsened by diabetes, patients with alcoholism because they're not absorbing things well. Again, starvation. If you're not eating much, you're not going to have a high potassium level. And then other diseases that cause absorption abnormalities, such as Crohn's disease, which makes your body not absorb these things properly. And then, as we just discussed, low potassium can also cause low phosphorus because it's not being reabsorbed in the kidneys. There are also some medications that can cause that. So we have to think about diuretics or water pills, which are often known for causing low potassium, but can also affect phosphorus as well. And sometimes antacids, because again, the absorption isn't there. So symptoms of low phosphorus. I will say I don't see this very often because usually our patients don't have extremely low phosphorus. It's usually pretty mild, but we can see anxiety or irritability, bone pain, stiff joints, fatigue, numbness, or weakness. And like I said below, often the cases that I see are asymptomatic. The patients have no idea and no complaints when I see them, and then their phosphorus comes back low. So we usually will replace that with oral supplements, sometimes IV, but not very often. And then go ahead to the next slide. So here's some food sources for phosphorus. So something to keep in mind, phosphorus is going to be present in protein-rich foods, nuts, cheese, fish, and beef. I had one patient who was unable to tolerate the phosphorus pills. And so we figured out that if he drank almond milk every day, his phosphorus was in the normal range. So that's what worked for him. So sometimes we have to work together to figure out what's the best option for you, because obviously some people do have dietary restrictions. All right, go ahead to the next slide. Next is magnesium. So magnesium has a lot of functions in the body as well. It's helpful for building proteins and strong bones, regulating blood sugar and blood pressure, just like our sodium and potassium. It supports muscles and nerve functions. It's an electrical conductor for your muscles. And again, similar to the phosphorus, a lot of it is stored in your bones. Go ahead to the next slide. All right, so low magnesium, also called hypomagnesemia. Causes include low intake, malabsorption, similar to the phosphorus we just talked about, and alcohol abuse. Diuretics and proton pump inhibitors like Prilosec or omeprazole or pantoprazole or Protonix. Any of those, similar to the phosphorus, can cause low magnesium. So symptoms of low magnesium are fatigue, weakness, decreased appetite, nausea, vomiting, numbness, tingling, muscle cramps, seizures, and abnormal heart rate. So you can see a lot of overlapping side effects from these things. So this is why when patients are experiencing these types of issues, we really want to check all the electrolytes. You can't rule out just one. All right, next slide. and foods for magnesium. I really like this picture I found online from your supplements. It talks a little bit more, not just the foods that are high in magnesium, but also kind of gives you a little background about how much is in each thing. So like, for example, dark chocolate. So that's going to be the higher percent cocoa, the more magnesium. So you can have 15% of your daily magnesium in a 1 ounce square, which is kind of nice little treat. Again, bananas are great. Chia seeds are a good one, and those also are high in omega-3s and iron. Yogurts, brown rice, spinach is good for that as well. All right, go ahead to the next slide. All right, and so since I was late starting, I apologize again, I am not going to talk too much about low sodium hyponatremia. So there are many, many different mechanisms that can cause low sodium in the body. It's a very tight balance with the water, but just to be aware of symptoms: nausea, vomiting, headaches, confusion or altered mental status, lethargy. And if it's low, really low, we worry about seizures and coma. So low sodium is a very big deal, something we take seriously. And then obviously the management of treating the low sodium depends on what's causing it. So that's a whole nother lecture we can talk about at another time. Go on to the next slide. So that's all I have for you today. I just wanted to thank my student, Angela Wu, for helping me with this presentation. Does anyone have any questions?
I see that there is one hand raised. So Warwick, if you had a question, if you can go ahead and put it in the chat or in the Q&A for us, we can make sure that we can get that over to Darcy. Thank you.
Thank you.
Excellent. Well, Darcy, thank you very much for that overview. It is a very broad topic, but it's the fundamental thing we look at in our patients, as you pointed out, with each of the therapeutic visits, to see that all things are in order to allow safely to proceed with the therapies that we have, which are, for their side effects, exquisitely dependent sometimes upon whether the sodium, potassium, and other electrolytes are within the normal range. And so I hope this has illuminated some of what we do when we replace magnesium or phosphorus, potassium, and other electrolytes in the course of your care. And if you have questions that pop up after, please just put them into the Q&A. We'll come back to them periodically, but it's almost time to move on to our next module. And so with thanks to Darcy, we'll proceed to Lauren Kirk, who has joined our team a couple of years ago in following someone who'd been for 6 years with our team as our first patient navigator. And it's a hard thing for me to imagine, and I'm sure for all of you in our patient community, how things worked before we had patient navigators there on the phone, available literally every day, and facilitating the entry of patients into the system, which is unfortunately much more complicated than we would like it to be, and requires many more elements for us to be able to make a proper assessment of patients coming in for treatment of one of the various cancers that we deal with. So with nothing more ado, we'll turn to Lauren Kirk, who is our patient navigator and central initial point of contact for all of our patients, family members, and supporters. Lauren, take it away.
Thanks, Dr. Kirkwood. I'm Lauren Kirk, and I'm the patient navigator for the Melanoma Center. Today, I'm going to talk about process of referrals. So we schedule with medical oncology and schedule with surgical oncology if needed. If they need surgery during seeing the medical oncologist, we'll coordinate the appointments for both of them the same day. Items I need to expedite the process are imaging on a CD, records, pathology, scans, office notes, labs, insurance info, and demographics. Insurance is like the top thing I need, because even if the patient is in Pennsylvania and they have an out-of-state insurance, that's where it gets tricky on getting these patients scheduled in a timely fashion. Patients that the providers I coordinate for are Dr. Kirkwood, Dr. Najjar, Dr. Devar, and Dr. Luke, and Dr. Sanave and Dr. Burgess, although Dr. Burgess does our sarcoma patients. You can reach me at my email, clarkle@upmc.edu, or my address, UPMC Hillman Cancer Center, 5115 Center Avenue, 2nd floor, Pittsburgh, PA 15232. And my phone and fax are located here too.
I think you unshared, Lauren. Maybe if you could reshare your screen.
No, it's because I think you're done.
Okay.
Dr. Kirkwood, I think she was all done.
Excellent. So sorry, I missed that. So I think it's hard to underestimate the importance of our Navigator in facilitating entry to the system, but it's an extremely complicated place. It's a one-stop number, one-stop email, and that number that Lauren gave you is open and something you can call when there are questions before a visit, after a visit when things are still hung up, and sort of as we all have provided our contact numbers at your initial visits in the center, Lauren is there to facilitate things in follow-up as well as in the initial entry to the system, the insurance and the other demographic stuff, which you don't have to do after the first time, and the management of any questions that may arise in regard to the treatment plans and the follow-up plans, which often are not self-apparent. Again, I see one question, although it's not popping up. So sorry, this is one for earlier for Darcy, so we'll come back to this perhaps. But I guess, Lauren, we're glad you're there. I know all of our patients are delighted that you're there, and thank you for your part in orchestrating the visits and all that is entailed for a patient to get into the system, which, as you pointed out, is fairly complex. Happily, for patients, it means that when you have a visit where you need both a medical oncology and perhaps a surgical oncology or perhaps a thoracic surgical oncology expert, Lauren can set up these visits before you've even come in so that the visit entails 2 or 3 other evaluations to save you time. Many of our patients come from 4, 5, 6 hours away, and this facilitation of the visit, the multidisciplinary care, as we call it, is, I think, a crucial aspect of optimal medical care for any cancer, but in particular for melanoma, where it often involves multiple subspecialists and multiple elements of data for us to be appropriately able to adjudicate care. Good. So I see a question, will slides be posted afterwards? And the answer for that is yes, the whole video will be posted. Eric, do you want to give us any details to where people can go or put it perhaps into the chat so everyone has access to it? That would be great.
Yes, the videos will be available on YouTube and on Facebook. Yes.
Excellent. And if you put the link in the chat, people will be able to get into that and have access to that, right from the get-go. And then with a minute before our next module would be scheduled to begin, Barbara has asked, should protein be increased to help with muscle fatigue? Darcy, do you want to answer this since we skipped over that Q&A for you?
All right, I was trying to start my video. Can you hear me?
We hear you and see you.
Oh, okay, perfect. Yeah, so that's a great question, Barbara. I think that in general, protein can help with muscle fatigue, but I would hate to give a blanket answer for everybody regarding that. I think it would depend on how much protein you're already eating and what your diet looks like. So I don't want to say yes and have everybody go out and do that because it's very personalized, but protein can help. Increasing protein can help with complaints of muscle fatigue if we've rolled out other causes.
And as Darcy said, I think it's an important caveat that you do this with the team, because sometimes there may be elements of kidney failure that we need to then modify the amount of protein that people take in. But if you talk with us about this, if there's any question of whether the protein level is sufficient in your diet, we'll happily discuss that. Good. Excellent. Well, now for one of two talks that have to do with stress. This has been a recurring theme and part of the queries we've had for all of the 37 or so years we've been doing the symposium. And one of the recurring themes, stress, will be addressed first by Chris Minier, a physician assistant in our program, and then by Lainey Francis in the very last talk in terms of holistic therapies and integrative oncology, which is a modality that many people have asked about. And so, Chris, take it away.
All right, thank you, Dr. Kirkwood. Good morning, everyone. Thank you for joining us today from all around the country and all around the world. Appreciate you tuning in. Like you said, I'm Chris Minier. I'm one of the PAs in the melanoma clinic. I work with Dr. Kirkwood and Dr. DeVar. So let's get started here. Okay, so my talk is about stress and stress management. So what is stress? Webster defines stress as a physical, chemical, or emotional factor that causes bodily or mental tension and may be a factor in disease causation. Stress can also be a state in which homeostasis is threatened or perceived to be threatened. So really, what can be a stressor? What is a stressor? And the short answer to that is anything can be. Anything that affects or threatens that state of homeostasis or is perceived as any sort of threat. And, that can be, money problems, health problems, issues with work, traffic, relationship struggles, things like anything, anything that you or your body or whatever perceives as a threat can be a stressor. And, even the littlest things can stress us out, and even big things like, of course, our diagnosis. And that's what so many, if not all of our patients deal with on a daily, weekly, monthly basis, all of that. So, the short answer is anything can be a stressor, big or small. And obviously in our patient's case, it's their melanoma oftentimes. And so how does your body respond to stress? In the immediate moments right after that stressor is perceived, you get a release of adrenaline, which causes your breathing rate and your heart rate to increase. And you also get an increase in glucose production, produces energy, fuel for your body, for your fight and flight response. So that's what happens in the short term of a stress, is your body's getting ready to react and to fight that stress or whatever it may be. But there's also long-term effects of stress, prolonged exposure to a stressor or prolonged moments of feeling stressed can have absolutely negative effects on the body, and they can affect your mental health. Obviously, being depressed, anxious, things like that. Can affect your heart. Heart disease is a big component of long-term stress. Obesity, type 2 diabetes, other metabolic issues, sleep disorders, so insomnia and excessive daytime sleepiness, also kind of circle back to the mental health effects of stress as well. You can also see some increased rheumatologic diseases, due to that chronic inflammatory state that stress causes on the body. You can be more susceptible to infections. You kind of, that old adage where you're stressed out for too long, you're burn the candle at both ends. Common cold just, you just get sick real quick. Things like that. And we've also seen, and research has shown, there's been an increase in neurodegenerative disorders such as ALS and Parkinson's and Alzheimer's. So the long-term effects of stress are absolutely prevalent and negative as well. So how to relieve stress? And I say this kind of tongue in cheek, but remove the stressor. Easier said than done. Obviously, you're having any sort of, relationship issue, money issues, things like that, that can sometimes, winning the lottery, things like that, doesn't always solve the issue, but, people think, oh, I get a bunch of money, I'm going to be happy. Not always the case. And especially in our patients with their diagnosis, that melanoma diagnosis, unfortunately, it sticks with our patients sometimes forever, even no matter how well they're doing years and years out, or how poorly that diagnosis can absolutely always stick with our patients. So, that's why I say it tongue in cheek, because you can't always remove that stressor, especially when you're talking about, a melanoma diagnosis and things like that. But there are ways to kind of relieve that stress. I say do things you enjoy, and I have a picture of Jordan Spieth and a guy cooking because I enjoy watching and playing golf, and I enjoy eating. So find something that you enjoy, something that you can do to try to take your mind off of whatever stressful situation is going on. If you can't always remove that stressor completely from your life, such as the melanoma diagnosis, but you can try to improve and kind of get rid of the stress a little bit. And there's some separate ways or other ways to kind of manage that stress. And Dr. Francis is going to speak a little bit about the integrative oncology program a little bit later this morning. But one way is with acupuncture. And that's just inserting needles, fine needles into the skin, certain places, certain points throughout the body to try to promote a natural healing and improve bodily function. There's also aromatherapy, which is essential oils and scents that help to, improve your mood and your state of well-being. There's meditation and yoga, which sometimes go a little bit hand in hand, are rather similar techniques, but meditation is where you just kind of deliberately focus your mind and attention to promote a sense of calmness and relaxation. And then yoga is using body positions, also with a little bit of posturing and meditation to promote that physical and emotional well-being. And this is just a small picture of the health and wellness suite and studios on the 3rd floor at Hillman, with the integrative oncology program that I said Dr. Francis is going to be talking about here shortly. So she'll give a little more information on that, but that's one resource that our patients at Hillman have available to them, and I know we have referred many patients up there, and it's a great program that she's running there, and just so beneficial to our patients. So thank you very much for listening, and what questions can I answer?
Excellent, Chris. Thank you so much for that. I actually don't see any questions for the moment, but since we'll have a second opportunity to address these after Lainey Francis's final discussion, we'll sort of await questions that are specifically related to this. There is one question, a patient with stage 4 disease, progression, spinal cord involvement, and the question relates to how THC and CBD can help to support the effort against the cancer. that's a little bit on the margin of what you've been talking about, Chris, but do you want to take that?
Absolutely. In terms of actually affecting the cancer per se, I'm just not sure. I can't really speak to, but symptoms, side effects associated with stage 4 disease, absolutely. Pain, THC and CBD can be very effective for some patients in controlling pain. Also, increasing appetite, decreasing anxiety, things like that. So THC and CBD are very beneficial substances in our patients if they feel that they need them and can benefit from them.
Excellent. And a next question is, what about SSRIs in stress management?
I don't see any reason why they would be contraindicated in our patients. Any type of modality, whether it be holistic, pharmacologic, anything like that, to help the mental well-being, alleviate stress in any way, increasing that serotonin, within the brain, I think it would be, is possibly beneficial for patients. Depression is real in our patients. Can be a big issue for them. So I think any antidepressant, anti-anxiety medication has the potential to be beneficial.
Yeah, and it's worth mentioning that we have an actively engaged behavioral medicine group and psychiatrists that we regularly involve where there's any question about depression as a component of the illness that a patient may have. So we've had that discussed in some depth in the past with Ellen Ormond. It didn't fit on the calendar this year, but I think it's something which very clearly we'll come back to in the future. Good. Well, thank you so much, Chris, and thank you to our participants for the questions that have been lively there. And right on target now, we will turn to a very new area, which in one sense isn't as new as it might seem, but what is called ctDNA, or the footprints of the tumor genetic structure that can be followed in the blood and measured in the tumor itself, is something that Melissa Wilson, our lead PA in the Outpatient Melanoma Center, will discuss. Melissa, take it away.
Thank you, Dr. Kirkwood. So good morning, everybody. It's nice to see everyone virtually on here. As Dr. Kirkwood said, I am one of the physician assistants in the Melanoma Center. I've actually been with our center since 2005, so I'm the old dog in this clan. Today, we're going to talk a little bit about ctDNA because of the amount of time. It's going to be a very, very long overview. We're not going to spend a ton of time, talking about the details, but you'll see ctDNA is something that I think is going to become extremely important moving forward with monitoring, especially. So let me just share my screen here, and then we will get started. As soon as I figure out how to start my slideshow. Okay, so here we go. So what is ctDNA and how is it helpful to us particularly in melanoma in this setting? So ctDNA stands for circulating tumor DNA. And remember that it's the DNA that comes from cancer cells or tumors, and that all cells, even cancerous ones, have DNA in their nucleus. And so what this test does is it identifies cancer-related genetic changes in the DNA from tumor cells that are released into the blood. And I have another, my next slide shows how that gets released. ctDNA has also been called a liquid biopsy. Although it can be obtained by a lot of the other bodily fluids like cerebrospinal fluid and saliva, it is extremely effective in monitoring with a blood sample. Most oftentimes, the blood sample is just a couple of tubes, so it really doesn't require a lot of blood. How does the ctDNA get into the bloodstream? Well, most of the DNA is inside the cell's nucleus, but as the tumor cell grows, some of those cells actually do die, as all cells do, and they are released into the bloodstream as they're replaced by new ones. So these dead cells get broken down and their contents, including their DNA, get kind of spilled into the bloodstream. And you can see from this graphic sort of a visual perception of how that happens. Come on, little computer. There we go. So what are the benefits to ctDNA? It can give us some potential tumor information, especially in instances where a tumor isn't available for biopsy. So historically, ctDNA isn't a new thing. It's been around for a while. And originally, it was really good at genetic profiling. So in patients that, say, in our case, we wanted to have BRAF testing for, in patients that unfortunately didn't have enough tumor in their original biopsy, or maybe didn't have a tumor that could be biopsied, doing a liquid biopsy or doing ctDNA could tell you a little bit about the tumor from a genetic or molecular standpoint. Also, obviously, there's a benefit because it's a blood draw with very little blood, just a couple of tubes. Some more advanced benefits are that you can identify clones of tumor, you can measure and track minimal residual disease. So this would be applicable for patients that were thought to have a complete response or were resected, or for patients like uveal melanoma after you have either radiation or an enucleation, for monitoring for recurrence with circulating tumor DNA, even prior to it being clinically or radiographically apparent. So some really exciting applications. This has been extensively tested in many of other solid tumors like colon cancer and head and neck, renal cell, ovarian. We're just really starting to get to the meat of potatoes and using it for melanoma. Some of the limitations are that if tumor isn't present, you might not have ctDNA detected in the bloodstream to get the wanted information. So this is referring to, if we want to get BRAF results, if you don't have any ctDNA that can be detected, we may not be able to get a BRAF result from your blood. Also, mutation results like genetic information, next generation sequencing, things like that. Sometimes the tumor may not be shedding enough cells to be detected, and this could lead to false negatives. This has been proven in some of the earlier studies. For any kind of meaningful immunotherapy monitoring, which is what we're in our specific clinic are starting to try to use this for as a companion test, you need to have multiple time points drawn. So ideally, we would like to draw this at baseline before you start treatment, and then at several time points, usually about 12 weeks with scans throughout treatment to kind of see, what the trend of the level of ctDNA is. And also at this point for melanoma, there really isn't enough data to use as a screening or monitoring tool yet. So we're working on that. There are multiple ongoing clinical trials that are available that, are monitoring this in our particular clinic. We're trying to get a lot of data for this, especially with immunotherapy patients now. So the take-home message about ctDNA right now is that we shouldn't use this in place of a tissue biopsy or scans really for making decision-making tools, but it is a great resource as a companion test. What has been done with ctDNA in melanoma? Obviously, we've talked earlier about it can identify mutations like BRAF, NRAS, TERT, et cetera. You can use it for tumor profiling, like mutational burden, local tumor environment. Some trials have actually already shown ctDNA detection of BRAF in the blood prior to the clinical development of tumor in an adjuvant setting. And this was done with Middleton et al. And so you can actually detect in this particular trial, it showed that patients with the BRAF mutation, you could actually identify BRAF in the blood with ctDNA prior to scans showing tumor. And also ctDNA is being used as a monitoring tool in response to immunotherapy. And it has been established. There's a company that actually has this indication as part of their FDA approval. So here is a graphic. It's a little hard to see, and I wish I had a pointer to be able to show you where I'm referring to. But as you can see on the graphic to the left, the first sort of picture with the person with their hands above their head shows lots and lots of tumor. And that corresponds to a ctDNA level that was quite high. And in this particular case, in the second picture over from the left, that patient had a very significant response to their tumor radiographically, and you can see the ctDNA in the bloodstream actually went down to 0 or undetectable. The same type of response can be seen with immunotherapy. In this case, the patient was then treated with ipilimumab, and they went from a undetectable ctDNA to some detection of their ctDNA in the blood. And radiographically, they did see this lymph node, a couple of lymph nodes actually, but this lymph node underneath the left arm. And then as they were treated, you can see their ctDNA levels sort of bump all around until progression of disease. So while this is a great tool to use in adjunct to scans, right now, we can't just do ctDNA testing and know whether or not your tumor is back for sure. So it's something that obviously warrants further testing in the future. So how can we use this in melanoma moving forward? What we're trying to kind of establish is an ability to help monitor patients. And especially this is important in people who with immunotherapy may have what's called a pseudoprogression. And so what we're trying to do is get a baseline draw and then draw again around each restaging assessment. These results come back pretty quickly once the baseline assessment is done. So in our particular clinic, I've been trying to draw patients like one visit earlier, right before they get their scans, so that by the time they have their scans and they're seen in clinic, we actually have these results to sort of draw upon. It can help identify quantitatively the tumor that may not quite be responding yet on imaging. So what that means is we just had a specific patient who radiographically looked extremely stable, but their ctDNA levels actually dropped quite significantly from their baseline level to their first staging assessment. And so while we didn't make any significant conclusions on that right now, because obviously this is still in the figuring it out stage, it's helpful information to know that we are making some type of impact, at least on the quantitative tumor that's circulating around. And as I said earlier, it has been shown in the past to show progression earlier. So those are important kind of prognostic things that we can draw from ctDNA. The other thing that I think will be useful in the future for ctDNA is to monitor patients post-surgically or post-treatment response. So this would be applicable to patients who, or maybe stage 3 or had stage 4 disease with a solitary tumor that was resected, where we, draw ctDNA, they don't have any quantitative disease at baseline. And then during the course of monitoring adjuvantly, they develop an elevated level that would prompt us to do scans and investigate that further. We could also potentially detect recurrence following complete response. So in the patients that, have a complete response to either targeted or immunotherapy, and we stop treatment and then are monitoring these patients with scans, we also could do ctDNA along with that to kind of look a little bit more closely. I kind of talked about these already. So detection of measured residual disease, screening for recurrence and metastasis, helping to interpret between pseudoprogression, especially with immunotherapy, and also to identify different clones of tumors. And all of these uses are actually being used in other solid tumors as well. So any questions? I know that this is a topic that probably gets a lot of questions in the clinic. Just randomly sit here and wait.
Melissa, I was blocked from starting video, but now I'm back on.
There you are.
So, thank you for that wonderful summary. This is really an emerging area that may be of use in detecting the disease, detecting recurrence, following patients in longer term treatment, and even deciding when to stop treatment. That is, I think, very exciting in terms of our research efforts. It may allow us to compare treatments one against another in terms of their benefit in ways that we have used other experimental approaches to in the past. But as I think Melissa pointed out, it's important to note that this is not yet a standard of care. It's being investigated. It's something which we'll hope to bring into play. But as we've always tried to bring to our patients, caregivers, and supporters, what's new on the cusp, this is certainly one of those factors. So since we have one question, so Kelly asks whether or how often stage 4 patients should be reassessed. You want to take that one, Melissa?
Yeah, that's totally fine. So typically we would want to reassess stage 4 patients, especially if they're on treatment. Well, Dr. Devar was going to answer, but we would want to do it every 12 weeks with scans of some sort, especially while they're on treatment. If you're referring to ctDNA, in our particular setting, we're trying to also do that every 12 weeks. Now, if there were some reason that we would need to escalate those scans sooner, like new symptoms, something that we would identify clinically, like a palpable tumor or a new thing on your skin, we certainly can escalate those scans to be sooner than 12 weeks, but really you need that amount of time to really see treatment response, especially with immunotherapy, which takes a little bit longer to kind of get the gears working. So, every 12 weeks really is our starting point.
Great. Well, thank you, Melissa. And
well, Devakar, I think Dr. Devar wants to say something, I think.
Yeah, no, Melissa, actually I had a question for you and Dr. Kirkwood. So the question that I have is really, we now have this new drug that has just been approved for choroidal melanoma, right? So first drug approved in the history of choroidal melanoma. Dr. Kirkwood was instrumental in the development of this agent. So a drug known as tebentafusp or Kimmtrak. So maybe, do you want to educate the audience as to one of the issues with the drug and maybe where ctDNA might be helpful in defining who is benefiting, or more importantly, who might not be benefiting?
Yeah, so I can speak a little bit to that, and then Dr. Kirkwood, you can go too. But essentially with these uveal patients, the drug was approved because it improved survival. And so a lot of times these patients, will have stable disease. Sometimes it makes interpreting, whether or not they're actually having benefit a little bit more complicated in the sense. And so, especially with the uveal population, it's really helpful to be able to see the levels of tumor DNA in the blood, because oftentimes, and we've seen this in the patient that in our clinic that we've actually drawn baseline levels on and throughout treatment, in the patients that responded, even though maybe their scans are very stable, we've actually seen some of that circulating tumor DNA go down in response. But also it's very, very good at detecting minimal residual disease. And so it's really good at if we do have patients that perhaps have, a very small tumor, or we're not sure whether or not they have gained all of the benefit from drug. And because this drug is given weekly, we can actually get really great, we can really follow them at time points to see how their DNA that's circulating changes. I'm sorry, Dr. Kirkwood, you'd be more specific than me.
No, I think that was appropriate. Devakar, does that answer your question? You want to embellish further?
No, actually, I think that, I just wanted to highlight the fact that this is a disease for which the response rate is 7% radiographically, but the benefit rate is 70%, as you guys showed in that New England paper. And so unlike, say, cutaneous or checkpoint inhibitor associated patients, where the dichotomy between patients who are responding or not responding is only about 5 to 10%, here the dichotomy is 90% of the patients who respond actually do not have any kind of radiographic shrinkage. So definitely, as Melissa was saying, in addition to MRD, potentially another indication wherein ctDNA would be very helpful for our patients.
Yeah, I think that it's a new dimension on disease assessment that will complement radiographic, the imaging assessment that we've done forever as the only way to assess by the criteria that everyone agrees upon whether a treatment is benefiting or not. Here, in particular, for Dependifus, the new agent in uveal, the fact that there isn't a tight concordance between objective shrinkage of disease, progression-free survival defined conventionally, and overall survival, it will be very important for our assessment. And I think, as I mentioned after Melissa's talk, the ability to follow ctDNA may allow us to compare treatments with one another and a control in the future in a way that will complement imaging assessment, which is the gold standard, but maybe in time to come, may be replaced.
I just want to really quickly, there was a question that came across, it looks from Facebook, and it was an anonymous attendee who said, I'm not feeling well, I'm tired and want to sleep. Can you tell me why? So obviously, if you're one of our patients, you should reach out to our clinic. There's actually an on-call number that will answer over the weekend, which I'm going to type to you in the box that Eric can send it to you. But you should definitely call whoever is taking care of you, because there are things that we can do to try to figure out why. So definitely call someone.
Yeah, I mean, the question had to do with a patient who's got symptoms on molecular therapy and wanted to know whether this was related to treatment. And I think it's something that the physicians taking care of the patient need to know about, as you pointed out, Melissa. Can be dealt with by interruption, dose modification, and because the patient is on BRAF inhibitor therapy, if push came to shove, the alternative therapies with immunotherapy would be a consideration. But that, again, is probably best dealt with by your physicians wherever you may be. Good. So I think we should proceed on and ask Kelly Francis to talk to us a bit about exercise as a way to augment supportive care of treatment and stress in follow-up of Chris's earlier talk and related perhaps to our last talk with Lainey Francis as well. Kelly.
Thank you so much, Dr. Kirkwood. I think the question that was just asked about fatigue with the patient on the BRAF MEK inhibitors kind of segues nicely into the presentation I'm about to give. So my name is Kelly Francis. I am a PA in the Melanoma Center, UPMC. I work mostly with Dr. Yana Najjar. And let me share my screen and be. Okay. Oops. Okay, so exercise for cancer fatigue. In my clinic, it's definitely one of the most common complaints that we see is fatigue. And this really is the most common cancer-related complaint across all cancer types, not just melanoma. So let's start with the definition here. Cancer-related fatigue is a distressing, persistent, subjective sense of physical, emotional, and cognitive tiredness or exhaustion related to cancer or cancer treatments that is not proportional to the recent activity and is interfering with the usual functioning. So we see about 50% of patients who are undergoing cancer treatment or have received cancer treatment in the past report fatigue as a distressing side effect. It's the most commonly reported side effect amongst all cancer patients. The prevalence of this increases to 75% for patients who have metastatic disease. And even 29% of people who have completed therapy can report fatigue as a disruptive symptom even years after treatment. So today, I'm going to briefly touch on some non-pharmacologic interventions that can hopefully help with fatigue related to cancer treatment, and improve quality of life. So for some contributing factors, one of the proposed mechanisms for cancer-causing fatigue is the pro-inflammatory cytokines, and cancer is an inflammatory condition, so increasing these cytokines can induce fatigue. However, it's rarely an isolated symptom. So it's important to, like Dr. Kirkwood and Melissa were saying, be evaluated by your medical team for secondary causes and to have a really multidisciplinary approach to treatment. This is very important for patients who are on immunotherapy, on targeted therapy, like that patient who had asked a question about their fatigue. Because new onset of fatigue or worsening of fatigue could be a side effect of a different problem caused by treatment. So it's always important to discuss these symptoms with your providers. Like we talked about, the immunotherapy and targeted therapy, one of the most common side effects that are reported in all the trials that are done with these treatments is fatigue. But there are some things that can happen with the treatments, such as endocrine dysfunction, hypothyroidism, adrenal insufficiency, things like that, that can contribute to fatigue. Anemia on your lab work cause fatigue, nutritional deficits, electrolyte abnormalities. These are all things that could contribute to why you're feeling more fatigued. Pain causes fatigue. Emotional distress can cause fatigue. After surgery, when you're deconditioned, you're not working out or you're not as active as you'd been before, you decondition pretty quickly, and that can lead to some fatigue as well. The medications that we're using to help negate some of the side effects that you're having from treatment, things that we're using to help with pain or nausea or even itching, these things can all cause fatigue as well. So it's really important to discuss this with your team, go over every medication you're taking, go over your labs, and kind of see if there's other things that can be intervened upon to help with your fatigue. One of the non-pharmacologic things that we can do that is very effective is exercise to help with fatigue management. So the NCCN, or the National Comprehensive Cancer Network, labels this as a Category 1 recommendation. And so what that means is that there is high levels of evidence and a general consensus across all people that this is a very effective treatment for patients and should be considered as part of their treatment regimen. Exercise has been proven in many, many studies to be beneficial in lowering fatigue and improving quality of life in all cancer patients and throughout the continuum. So when they're starting treatment, when they're on treatment, and even after they've completed treatment. So how do we get started? I think it's very important to have more resources available to you. So adding more people to your treatment team, like physical therapy and occupational therapy, to help augment the treatment that you're getting for your cancer, helps you to have a better quality of life and to be able to hopefully tolerate these treatments better. So before you start, you should obviously talk to your healthcare providers, make sure this is something that is safe for you, assess your level of conditioning, and hopefully meet with a physical therapist, occupational therapist, and develop a plan that can be sustainable for you, where you can start with some low intensity, short duration, and then increase that intensity and duration as you increase your endurance. There's no set guidelines that are recommended for how much activity or what types of activity are most beneficial, but in majority of the studies that I looked at, they recommend both cardiovascular and resistance training, and these really helped with combating fatigue related to cancer and related to cancer treatment. So these exercise programs should really be individualized based on the patient's performance status, what are their comorbidities, what is their fitness level coming into treatment, and what is a realistic goal and expectation. And I think it's very important to set goals that are manageable and hopefully reach those goals and then establish new goals. A general recommendation for all adults from the Surgeon General is 150 minutes of moderate intensity aerobic exercise per week. But of course, this is something that needs to be individualized based on how a patient is doing. Another non-pharmacologic intervention is energy conservation. And I think this goes hand in hand with developing a good exercise program. And so I think our occupational therapy colleagues are really important in helping you develop strategies to conserve energy, and which can help you build up strength and then take part in the daily activities that you need to do, and most importantly, the things that you want to do. So here are 4 Ps that are kind of a rough guideline of things to be thinking about so that you can spend less time on the things you feel you have to do and you are able to do things that you want to do, and being able to enjoy the aspects of your life that you want to be doing. So one thing is to prioritize, so figure out what's important, what needs to be done, and what can maybe put off to another time, another day. Planning your activities, so if you're going shopping, you don't have to do extra trips later on in the week or later on in the day. Planning on alternating your heavy and your light tasks so that you have time to rest. Plan ahead of time for things that maybe could be delegated to friends or family. Maintaining a slow pace and resting often is very important. You may need to rest even before you start to feel tired. That way you can continue to have your endurance throughout the day. There are some breathing techniques that can be beneficial in conserving your energy and making you feel better as you're doing whatever the task is that you're doing that day. And then position. This is where I think it's really helpful to have the occupational therapists involved. Bending and reaching can really cause you to fatigue even quicker. So using some adaptive equipment or equipment that can hopefully be labor saving can conserve your energy and help you to maybe be able to do an exercise later on or have more improved quality of life while you're on these treatments. And so just in conclusion, physical activity has been shown to improve cancer-related fatigue. It also improves mood and it can improve treatment tolerance. So if you're feeling better, you can obviously tolerate the treatments that we're giving you much better. I think it's really beneficial to talk to your providers about what you're experiencing. I know everyone experiences some level of fatigue and we sometimes write it off, but it's really important to talk to your providers so that they know what you're going through and maybe even getting some more experts on the team like physical therapy, occupational therapy, doing additional workup with labs and things like that so that hopefully we can identify any secondary causes and then make you feel as good as you can while you're going through these treatments.
Excellent. Thank you so much, Kelly. I've been blocked from video, but hopefully Eric will let me on soon. Okay, there we go. So basically, with this, we will conclude the first hour of our session today, and I will pass the baton to the co-leader of our melanoma program, Hassan Zarour, who is on video and I think ready to take it over. Hassan.
Yeah, thank you, John. We're going to keep on for the second part of the symposium. So my name is Hassan Zarour. I co-lead the program with John Kirkwood, more involved in the translational study in the lab side to try to understand why people respond or do not respond to treatment. And I would like to take this opportunity to thank all the patients who very kindly accept to be consented to banking protocol, to provide blood, serum, or even stool. Now, I think these are very important for us on the other side in the laboratory to better understand and find potential new therapy for the patients. So without any further delay, we're going to keep on this exciting symposium. And Amy Rose, who is a program manager of the melanoma program, is going to talk about the protocol office and clinical research coordination. Amy, it's up to you.
Hi, Dr. Zarour. Thank you. Yes, my name's Amy Rose. I am the clinical research manager of the Melanoma Center. I've been working with Dr. Zarour, Dr. Kirkwood since 2008. So like Melissa, I'm one of the old people here as well. I just want to talk a little bit today about clinical research. Share my screen here. Okay. So what is clinical research? Clinical research, they're clinical trials that are research studies humans just to evaluate for new medical techniques. Typically, we look to find the safety, tolerability, and optimal dose of new drugs. And we also look to see what drugs we can use in combination. Usually these are combining a new drug with a drug that's already been approved, typically by the FDA. So every drug that is used in cancer care, whether it's one of the PD-1s or the CTLA-4s, they were all used in clinical trials prior to becoming FDA approved and open to outside of clinical trials. The goals of clinical research is to develop more effective treatments than what we have as the standard of care. We have a lot of drugs that are now FDA approved, but we continue to search for drugs that will work in either different types of melanoma, different stages of the disease as well. We're also looking to improve side effects for safer, more tolerable treatments. A lot of times that the drugs, when we start with the drugs in the clinical trials, we have to kind of work to find the best way to manage all the side effects that do come along with it. It is a learning process that happens with it. And then the ultimate goal is for regulatory approval through the FDA, where then the drugs are now available outside of a clinical trial, maybe at some local community sites as well. That way, a lot more patients will have those treatment options. But all of the medications that are FDA approved did start in clinical trials and were available to patients through the trials prior to FDA approval. So why participate in a clinical trial? Some very important reasons. Number one, to contribute towards the advancement of science, to help find a cure. If not a cure, help at least find something that might prolong survival or cut down on the rate that the disease is progressing. Being in a clinical trial also has you take on an active role in your own healthcare. You will learn a lot more about melanoma or the treatments that are available by participating in a clinical trial. The participation is always at will. It's completely voluntary. At any time, you're able to withdraw consent, whether it's, if you're having trouble with the side effects or maybe even with trying to get to the Hillman Cancer Center to participate in the trial. At any time, it is completely voluntary for you to withdraw consent. We do ask that you speak with the physicians prior to doing that, though. It does have access to new medications. A lot of the medications are not available outside of a clinical trial and would only be available after signing consent through the Hillman. And there's also additional care that's involved, meaning our clinical research staff are available to answer any of your questions, even if it's, a day that you're not in clinic, you're able to call the clinical research team and get your questions answered, or if you're having any side effects or problems, by all means, you'll be able to reach out to them at any time. So a lot of people ask about the safety of a clinical trial. So clinical research is designed to give the safest, most effective clinical treatment options. All medications are reviewed in laboratories and are studied in animals prior to being used in humans as well. And again, patients are monitored very closely by the clinical research team. You will see your clinical research coordinator at every visit that you're in. You'll see the physicians, the PAs, the collaborative practice nurses as well. They all work together to make sure that you are able to manage the side effects and continue with your quality of life as well. We do review patients every week. We have a meeting, review all patients that are in screening or on clinical trials or even in follow-up to make sure that there's no issues that we're missing at all. And then also just to know that clinical trials are reviewed prior to being open and recruiting for patients. We have a medical and scientific review of all clinical trials that come through. We also have the institutional review board that has to approve any clinical trial prior to patients going on. The institutional review board, or the IRB, is made up of physicians, scientists, lawyers, and other people that review to make sure that the trial is something that would be safe for participants and is something that would be manageable for the participants as well. And a lot of the trials also have to go through FDA review prior to being open for patients to be treated on. The FDA reviews, again, make sure that everything is safe prior to proceeding. So I just wanted to quickly review some of the phases of clinical trials. We do have a lot of phase 1 clinical trials. These trials are very new drugs. They test the safety, side effects, and doses of new medications. A lot of times it's looking at dose escalation, where you'll have a few patients that will start at a very low dose. And as long as that's tolerated well, we'll move on to a little bit of a higher dose. And we do that until we find what's called the maximum tolerated dose. It's the highest amount of drug that we can give with the least amount of side effects as well. These phase 1 trials are typically treated in multiple types of cancer. So it would not just be, for instance, a melanoma patient. You might have a patient with lung cancer or colorectal cancer on here as well. And it's usually a very small number of patients, sometimes as little as less than 60 patients on a phase 1 clinical trial. The phase 1 trials do have a lot of what we call PKs, pharmacokinetics, where we are testing the blood to see how much of the drug is found in the blood at certain hours after the medication is infused or given. So there is usually a lot of times where you'll be on a phase 1 clinical trial and you will be at the Hillman for sometimes longer days. Sometimes we can go up to as much as 6-8 hours after the drug is infused to test to see how much is in the bloodstream. Phase 2 trials are typically tested in a certain type of cancer. So after it goes through the phase 1 trial, they usually see which disease it works best in. The dose is found from the phase 1 trial, so it's the maximum tolerated dose. And it's looking at, does the new medication work? Does it have, is the disease responding to it? And this is typically a moderate group of patients, usually around 50 to 100. And then after the phase 2 trials are completed, we do move on to phase 3 trials. The phase 3 trials are typically randomized trials, meaning you'll either receive the standard of care treatment, which is already FDA approved, versus the study medication. Other types, we do have a lot of combination trials where, again, you might receive, for instance, a FDA PD-1 inhibitor in combination with the study drug as well. The phase 3 trials usually have a very large group of patients, anywhere to the hundreds to thousands of patients that are involved. And then lastly, we do have phase 4 trials. These are already FDA approved drugs, but the FDA would like to continue to do research on it. A lot of times they're looking at other factors, not so much how the disease responds or the side effects of it, but more like the quality of life of the trial, or what's the cost effectiveness of the trials as well. Phase 4 trials typically have thousands of patients that are involved in the phase 4 setting of the trial. So there are different parts of a clinical trial. It always starts with informed consent. So the physician, the PA, and the clinical research coordinator will be able to consent the patient. The purpose of the consent is so that the participant is completely aware of everything that's involved in the clinical trial, all of the possible side effects of it, how many times, how many days a week or how many days a month that you'll need to be at the Hillman to receive your treatment or have other testing done. It reviews the risks and benefits and also compares to what your other options of treatment would be, whether it's a standard of care or another clinical trial, or even observation in some cases. After the patient and the physician sign consent, they then move on to what's called the screening or evaluation or eligibility review. So every clinical trial has an inclusion or exclusion criteria laid out that all patients have to meet in order to participate in the study. This is just a safety to make sure that the patients are safe to proceed with the medication. A lot of times the screening evaluation will include CT scans, MRIs, lab work. Sometimes there'll be EKGs or echoes. There's always a physical exam by the physician and PA as well. And all of that information is then reviewed by both the clinical research coordinator, and we also do a second check, and then the physician or PA ultimately signs off to make sure that the patient is eligible for the trial. So once the screening evaluation is complete, the patients will then move on to what's called on-study or active treatment. That's when the actual clinical trial process starts. The treatment itself will begin, and typically that's what we call day one. And from there, the protocol lines out what days you would need to be in for treatments. If there's any windows where we can move, whether you have a vacation planned or something, we can always try and work with that to make sure that you're still getting your treatment, but still being able to live your life as well. And then the last phase is the follow-up phase. A lot of times when patients come off treatment, whether it's if the treatment is completed, or a lot of treatments are set for maybe 1 year or 2 years, we do go into what's called survival or long-term follow-up. But before we do that, we also have safety follow-ups where we just review to make sure at the end of the trial, any adverse events that happened, any side effects from the treatment are taken care of or have resolved back to baseline prior to you coming off of the treatment. So my clinical research team is, we have a very large team. The clinical team is involved. This includes the physicians, the physician assistants that you'll see on a regular basis during the treatments, as well as collaborative practice nurses. They work very closely with physicians and just take any phone calls and stuff the patients may have, or if you need standard of care treatments while you're on a clinical trial, the collaborative practice nurse will help with that. Such as if you're having, a side effect, you might need, for instance, a medication for nausea. The collaborative practice nurse will help be able to get that medication to you. We have a clinical research manager, which in my position, we work to lead the team to make sure that you're getting the best care from the research team. We also make sure that we have clinical trials available that are open and available for every stage of melanoma. Whether it's in the adjuvant setting, after you've had surgery, whether it's a neoadjuvant setting, so you have treatment prior to surgery, and then treatment again after your surgery is completed, or if it's in the metastatic setting, whether it's a front line where you've never had treatment before, or even a second line or third line treatment. We want to make sure that all of those options are available for patients at any time that they might need them. We also have the clinical research coordinators. They are essentially the face of research. They are all registered nurses, and they see all of the patients on the clinical trials every time that they come in for their treatments, or if they're just coming in for a follow-up visit. You will see the clinical research coordinators. You will also have a direct line, their phone number. If there's any problems or issues, you can call them, and they'll get back to you that same day as well. Working with the clinical research coordinators are the research associates. They are in charge of a lot of the data entry. So when any of the side effects that you report, any changes in medications, all of that information is gathered and entered into databases by the research associates. They are also in charge of preparing your lab kits with the PKs that I was talking about previously. They make sure that all of the research labs that are outlined in the protocol are available and able to be drawn at the time points that are needed. And then we also have the regulatory specialist. Their job is very much behind the scenes. In fact, most of them work from home completely, and they work with the internal review boards and the study sponsors to ensure that the most recent versions of the protocol are up to date and available for the clinical research team. They make sure that the IRB and the FDA has reviewed and approved these protocols prior to it being active and available for the patients as well. So we have, like I said, a very large group of individuals that work very closely to ensure that these clinical trials are available and are the safest possible for all of our patients. And finally, I just wanted to end with a thank you. A huge thank you to all the patients that have participated in clinical trials. Without your participation, none of the drugs would be approved through the FDA and would not be available for all of the patients with melanoma at this time. So I do want to just say thank you so much. And I'll take any questions if you have any.
Yeah, thanks, Amy. That's a very exciting talk and great talk. I see no question in the chat box yet. So Divakar, you want to ask something?
Yeah, sure. Actually, I did. I think Amy, it'd be probably beneficial for the patients in the call for you maybe to kind of briefly, walk through, when we think of what is the screening window, oftentimes it's a bit of a puzzle as to why we actually have a screening window, for people who don't necessarily do clinical trials. But maybe you can briefly explain the importance of the screening window, the second check process, so that patients understand, the checks and balances that go into enrolling into a clinical trial.
So the screening window is typically around 28 days from when you are signing consent. So the clock essentially starts at the time of consent. And we have, within those 28 days, we have to have all of the CT scans, the lab work, the echoes, EKGs, physical exams completed prior to starting the clinical trial. It's such a small window because we want to make sure that the patients are the safest and best point to be able to start the clinical trial. We do have, as Dr. Dvar mentioned, the second check. And so the clinical research coordinator will go through, pull medical history, all the lab work, results from the scans and everything, and compare that to the inclusion/exclusion criteria laid out in the protocol. A second check is done typically by myself as the manager or the quality assurance team. And then there's even a third check done by the physicians. And again, it's just reviewing medical history, lab work, scans, everything to ensure safety for the patients prior to starting the clinical trial.
Yeah, thanks, Amy. I just want to reinforce that clinical trial are really critical to our mission to provide patient, to answer their unmet need. We have many success in treatment of melanoma, but there's so much work to do. And so this is critical, I would say, not only to provide new treatment, new combination, but also to understand and this is emerging data that show the way and sequentially how we treat the patient might be important, starting with immunotherapy or targeted therapy versus targeted therapy or immunotherapy may have an impact in the long-term benefit of the patient. And there are some emerging data that allow us to understand better this and to treat better the patient. Very good. Thank you so much, Amy. So we're going to switch to the next talk. It's a pre-recorded talk given by Dr. Jason Luke, who is a member of the melanoma program and also director of the Cancer Immunotherapy Center at the Hillman Cancer Center. So,
hello, I'm Jason Luke from UPMC Hillman Cancer Center in Pittsburgh. I'd like to thank the organizers of the meeting for the opportunity to speak with all of you today. I'm going to be speaking on the development of new immunotherapies for melanoma. The title of my lecture today is The Future of Metastatic Melanoma Treatment. And so just to level set for everyone in the audience, melanoma therapy is really split into two categories at the current time. The first is using BRAF-directed therapies, which is outlined on the left-hand side, where you can see that normal cells have a growth pathway dependent on sort of getting food. We call it a ligand that drives signaling through these different proteins. But we know that in melanoma, approximately half of melanomas have a mutation in a gene called BRAF, most commonly V600E, that turns this pathway on all the time, even when the food is not around. And so because of that, developing drugs to block BRAF or MEK have been standard treatments in melanoma and very effective. By contrast, we use immune checkpoint blocking immunotherapy as well, with drugs like ipilimumab, which blocks the molecule CTLA4. And that's a protein that regulates the on switch, so to say, for immune cells. Another immune checkpoint is the PD-1 or PD-L1 axis. And by blocking this, we can wake up immune cells that have come to fight the cancer, but been put to sleep. So a number of different immune therapies are coming forward and likely to change the standard treatment for melanoma in the next few years. And the most urgent of these, The most recent of these is going to be that of LAG3. So LAG3 is another protein on immune cells that are what we call dysfunctional, meaning they've come to find the cancer, but they haven't been able to kill the cancer. And a clinical trial has been performed and results are in now for combining a LAG3 antibody called relatlimab with nivolumab in patients with melanoma, showing a superior outcomes compared to those patients who got nivolumab alone. And this new treatment, relatlimab, is going to be reviewed by the FDA and we assume approved near the end of March in 2022. Another new kind of treatment that's coming forward and that we've had a big impact on at the University of Pittsburgh has been the development of this molecule called vidutolimod. And who comes up with these things, right? Well, this is a very interesting drug that has an immune stimulant called a toll-like receptor 9 agonist wrapped in the particles of a virus. And we call this a virus-like particle. And the reason this matters is that the virus-like particle is noticed by the immune cells and taken up into immune cells because they think it looks like a virus. But upon doing that, the immune stimulant is released, which can actually drive immune responses to be enhanced by other immunotherapies to fight melanoma. And in a group of patients who had already had standard therapies, giving this drug alone or with pembrolizumab showed that about a fourth of all the patients would have their tumors shrink. And this treatment was generally speaking safe, with only some low-grade flu-like symptoms upon injection into the tumor. Another therapy to be aware of is a new version of an old therapy in melanoma. So historically, we gave a treatment called interleukin-2 that could drive some patients' immune systems to get rid of melanoma, but caused a lot of side effects. And so a new kind of IL-2 molecule is this molecule, and it has a great name. It's called bempegaldesleukin. And the drug preferentially tries to turn on the good parts of IL-2 and leave aside the bad parts. And the drug has been designed so that it releases this molecule slowly over time to stimulate immune cells of various kinds to drive responses against cancer. And on the right-hand side, you see what's called a waterfall plot showing each patient's tumor and how much it shrank. You'll notice this minus 100%. So almost 40% of patients in this trial of bempeg plus nivolumab had complete response or eradication of their cancer. And this is very exciting. A phase 3 clinical trial is already completed, and we're awaiting the results for this clinical trial any minute, actually. A further therapy to be aware of is combining different kinds of cancer treatments. And so a category of blood vessel blocker drugs has been around for a long time in cancer. And more recently in melanoma, we have found that combining them with immunotherapy with PD-1 antibodies might be successful. And the reason for this is getting rid of abnormal blood vessels allows immune cells, CD8, to come into the tumor. And it turns out these drugs have other effects on other immune populations, which also can be enhanced by drugs like pembrolizumab. And again, in a cohort of patients who had previously received standard drugs like Nivo, Pembro, and Ipi, we saw that treatment response could be observed in 20 to 30% of those patients, which is really promising given that this is an early phase clinical trial. And so we'll shift gears slightly now. Those were all treatments that were being developed for patients who had never had a treatment before. What about those patients where the treatment has stopped working? Well, one approach is to try to deliver really powerful immune molecules called cytokines into the tumor. And so one of them is interleukin-12. And interleukin-12 can drive a lot of immune effects that can be augmented for immunotherapy. And this is a little bit of a complicated drug. It has a great name called tavokinogene telesplasmid, and it is literally injected into the tumor, followed by a slight electrical signal, and then combined with immunotherapy like pembrolizumab. And what you can see is this can lead to regression of tumors and this huge, sort of burst of immune activity after delivery of this drug. And a phase 3 clinical trial is looking at this combination now. There's been a lot of interest in our field about harnessing patients' own immune cells to fight their cancer, something called autologous tumor-infiltrating lymphocytes. And here, the patient comes in for a surgery where the melanoma is removed. We take the immune cells out and grow them in the lab Then we bring the patient back and give them back their own immune cells. And in clinical trials, this has also been shown to drive long-term immune responses that lead to disease shrinkage in some patients. And again, we expect this to be approved by the FDA in the coming year. The final one to be aware of is a breakthrough in immune engineering using T cell receptors, or the recognition switch on immune cells. And this drug, called tebentafusp, is an ImmTAC molecule with two parts: a targeting domain with the T cell receptor that recognizes an melanoma molecule called GP100, and connected to another part called an effector domain, which binds to immune cells. So this literally pulls immune cells into the cancer. And that can lead to very improved immune responses, and actually has led to the improvement in survival of patients with uveal melanoma, a rare subset of melanoma in the eye, which metastasizes to the liver. And this is the first drug ever developed just for that subset of melanoma. So in conclusion, combination therapy is clearly the future of melanoma and probably all cancers. There are many novel immunotherapy approaches that are being developed, including all those that I covered today. And I hope you found that useful and interesting. Thank you very much for your attention.
Okay, Jason is not here with us today, so wonder if there is any question here. And one question asked by an attendee: I have stage 3A BRAF non-V600 and RAS-positive melanoma. I started on Nivo, developed erythema nodosum and pneumonitis after 3 treatments, and treatment was stopped. Most clinical trial combined with an ICI. What is available for patients in this situation? So, Diwakar, you want to take this question? So,
yeah, sure. I guess the first thing to keep in mind with stage 3A melanoma is to keep in mind that patients with stage 3 melanoma actually have a relatively good prognosis, right? So when you think of all stage 3A disease, with the new AJCC staging classification, 3A disease actually, which focuses on patients with relatively thin tumors and microscopic node-positive disease with just one node, these patients have a relatively excellent prognosis. So the 5-year relapse-free survival rates are 6%, and the 10-year relapse-free survival rates, relapse risks are 12%. And so immunotherapy really just cuts those risks by half, right? So the first thing to keep in mind is that even if somebody like with 3A disease was seen in a clinic, one of the major considerations is whether or not these patients should even be offered immunotherapy at all. And it's also important to keep in mind in this case, at least in the Merck in the Merck trial compared to the BMS trial of adjuvant immunotherapy, the BMS trial of Checkmate 238 actually excluded 3A patients. The Merck Keynote 054 study included them, but the Bristol Myers study actually excluded 3A patients precisely because the relapse risk of this patient population was low. The second thing to keep in mind is that when you have 3A disease, we don't know, for example, whether 1 treatment versus 12 treatments is enough. You know, nobody quite knows how many treatments you do need. In fact, the entire duration of therapy discussion actually is a hangover from the days in which the treatment for adjuvant therapy for melanoma was primarily high-dose interferon. So the other important question is to say is, if you had 3 treatments and treatment was stopped, it is not necessarily a bad thing, because you don't necessarily know that the treatments didn't do anything. Clearly, because in this case, one had side effects. The last thing to keep in mind is that if you have a non-V600 positive disease that is NRAS positive, there is no FDA-approved treatment or a clinical trial that are enrolling patients. And the vast majority of IO studies in this setting, whether they are with vaccines or non-vaccine-based approaches, would exclude patients with a prior significant side effect. So the main thing to keep in mind in this case is, definitely close monitoring is required, close surveillance with CAT scans, possibly even ctDNA, because it's even more accurate than imaging to pick up recurrence. But I wouldn't necessarily be too. I would be quite optimistic about the prognosis of 3A patients, because it definitely is a separate subgroup compared to even 3B and particularly 3C or 3D disease, where the prognosis is actually much more favorable for 3A disease with microscopic node-positive disease and a thin primary.
Okay, thank you so much, Jakar. I just want to update. So this was registered, a pre-recorded talk by Jason Luke. He talked about many combination. And what we have heard since he recorded that effectively the combination PD-1 and LAG-3 is approved. So it becomes approved as a frontline therapy for advanced melanoma. So now you can be treated with this. It's FDA approved. This is the good news. On the bad side, he talked also about this BEMPEG IL-2-like molecule that was tested in a large phase 3 in combination with Nivo as compared to Nivo alone, and this has failed. So you're not going to be treated with this combination as a first-line treatment. So so we still don't understand the consequences of that. Much work remains to be done in this area of IL-2 type treatment of melanoma. Very good. So we're going to keep on and go to the next talk. And so Dr. Davar, member of the program, is going to talk about the microbiome intervention in cancer immunotherapy. Yeah, Karen, it's up to you.
Okay. So thank you all for the opportunity to talk about the work that we're doing here. So I just want to highlight that the microbiome efforts at the University of Pittsburgh are definitely front and center. This work is actually being co-led by many people within the program, particularly the co-leader of the program, Dr. Zorro, from whom you just heard, as well as myself. And we've got a very interesting set of interventions and that are potentially you'll hear a little bit about today. So these are my disclosures. So, immune therapy is really transformed the life of patients with melanoma. And you just heard, for example, with Nivorella. And also the really two big news in the last couple of months is the role of adjuvant, the expansion of adjuvant checkpoint in the adjuvant setting to stage high risk, no negative stage 2 disease, which is stage 2B and C. But basically the point is that about 70% of our melanoma patients, so 70% of 100,000 people in the United States have access to checkpoint inhibitor immunotherapy, no matter where you are in your life cycle, whether it's stage 2B, C, stage 3, stage 4. And what we do know about these patients is that one of the really important aspects is that the intestinal microbiome or the gut microbiota that you have in the 20 feet of bowel, all the way from the distal small bowel all the way until the stomach, all the way until the rectum, actually affects the likelihood of response to checkpoint inhibitor immunotherapy. So the data behind this actually comes from several different groups. You can see here on the left data from MD Anderson, in the middle data from Chicago, and on the right data from France, showing all kinds of different organisms being associated with differential response to checkpoint inhibitor immunotherapy. But the key point is the organisms are very different. And why is that? So in order to answer this question, we actually did a large study that I'll talk about in a little bit. But this idea that there's a huge difference in organisms between people who do better and compared to people who do poorly was actually highlighted in this meta-analysis as well, where you can see that across all these different studies, the studies are listed in the horizontal lines and the organisms are listed in the vertical columns. There is really very little concordance between what's good and what's bad. In fact, you see, for example, Faecalibacterium prausnitzii, 3 studies found that it's kind of favorably associated, and 3 studies found that it's unfavorably associated. So the real question is, why is this happening? And so in order to understand this, what we did was we did a very deep dive into this, and this data has now been published. And the first thing and the most important thing that we identified was that it's very clear that the gut microbiome separates people who do well and don't do well. Now, it's very interesting that it appears to do so at least at a very particular time point. And in the context of patients with advanced cancer who are receiving checkpoint inhibitor monotherapy, so this is nivolumab or pembrolizumab, the time point in which this appears to be important is about 9 to 10 months. That means after about 6 months, and definitely before 1 year, but closer to 1 year than 6 months. And it's around about the time point in which the vast majority of people who are failing immunotherapy actually appear to fail immunotherapy. We can identify that a vast majority of these organisms that appear to be favorably or unfavorably associated, favorable in blue and unfavorably in red, that were identified by other studies were actually picked up by our data as well. What this suggests is, very importantly, part of the reason why there were very many differences between the patients across these previously reported studies really has to do with how people defined what was good and what was bad. So if you define what's good and what's bad based on, an arbitrary definition of cancer shrinkage or cancer growth, you don't necessarily pick up all the organisms that are associated with good and all the organisms that are associated with badness. More importantly, if you define what is good and what is bad in terms of landmark survival, that is likelihood of response at a certain time point or non-growth of cancer at a certain time point, you identify all these organisms and you have a nice unifying hypothesis. Separately, it is also important to keep in mind that function is more important than form. And what that suggests, or that means, is that when we've looked at the genes that these organisms carry, the vast majority of the organisms that appear to be beneficial have very, very similar genetic composition, suggesting that even if organisms may appear to differ across different cohorts separated by geography, they may actually mean the same thing as long as the genetic elements are the same, suggesting that before you talk about what organism is good and what organism is bad, you need to know whether or not the genes that organisms carry are favorably or unfavorably associated with checkpoint inhibitor immunotherapy. Now, separately in the same work, we also identified that the bugs that one carries is also associated with side effects, immune therapy related side effects. You can see here that patients with side effects have very different metagenomes, meaning their organisms are very, very differentially distributed. And the likelihood of at least one particular organism causing a variety of different side effects is very differentially distributed, in this case, Streptococcus. And indeed, Streptococcus, which is not a commensal that is normally found in the gut, when we wondered why it was being found in the gut, we hypothesized that the only reason why Streptococcus, which is found in the mouth, can go to the gut is possibly because you're taking something, a patient is taking something that somehow artificially raises the gastric pH, raises the level of acidity in the stomach that is normally supposed to be present to prevent these bugs from going to the gut. And indeed, when we found that actually high levels of strep was associated with checkpoint inhibitor patients who were receiving proton pump inhibitors. And previous studies have looked, have said that side effects are largely speaking favorably associated with survival differences in patients with checkpoint inhibitor treatment. But some side effects, some other studies suggested that this wasn't the case. And when we did this analysis all over again, we found that this analysis was largely, difference in the analysis was largely associated with the presence of this adverse species Streptococcus. So the point is, organisms are associated with favorable as well as unfavorable outcomes of checkpoint inhibitor immunotherapy, but also very interestingly, organisms are also associated with the development or non-development of side effects. Now, in that context, what we've separately tried to do, and some of you on the call have actually participated in these clinical trials, we've actually sought to intervene with an intervention in patients who have non-responsive checkpoint inhibitor immunotherapy to see whether by changing the gut microbiome, whether we can elucidate response. And so in this kind of really proof of concept clinical trial that was done about 3 years ago, we gave people a single fecal transplant derived from a responder to patients who were not responding to checkpoint inhibitor immunotherapy, and we kept them going on the pembrolizumab that they were otherwise getting after an extensive series of serological matching between recipients and donors. And what we found was that about 15 patients who were treated, 6 out of the 15 patients had some kind of radiographic stabilization of disease. So the cancer either stopped growing or the cancer shrank. And these responses were long-lived. And many of these patients actually are still being followed, either with stable disease or response. Some have actually stopped treatment and are just being followed. And what this tells us is that provocatively, a single fecal transplant designed to change the gut microbiome can actually produce responses in patients who are otherwise completely resistant to immune therapy. So it's a very provocative idea, and it's something that is now undergoing further testing. Finally, some important translational questions to think about, and that is, can this work in other cancers? Now, to test the hypothesis in both melanoma as well as in other cancers, we are now embarking on the next generation of clinical trials. And the next generation of clinical trials focuses on one, in non-small cell lung cancer. If checkpoint inhibitor therapy is great in melanoma, it's equally provocatively important in non-melanoma cancers, including lung cancer, which affects 3 times as many people as melanoma. So let's try and see whether we can help lung cancer patients. And so in order to test that, we've developed a trial. We've gotten some funding from the NCI in the form of a large UO1, which Dr. Zaror is the PI of, as well as a separate foundation grant from Gateway that I'm the PI of. And we've now got a new study in which we're going to do this in non-small cell lung cancer. But also, we've got another study in which we're going to test this out in melanoma patients, building upon our earlier observations of checkpoint inhibitor therapy primary response being fixed by a fecal microbiome intervention. What we're going to do is we're going to do this in combination with pembrolizumab and lenvatinib. So in melanoma patients, this combination of pembrolizumab and lenvatinib is a combination that is currently undergoing registration in 10 trials in both the relapse refractory setting as well as the frontline setting. The data is not out yet, but we're going to be giving patients with refractory melanoma access to a clinical trial in which patients are going to be randomized to either this combination, pembro-lenva, or pembro-lenva plus a microbiome intervention to try to see whether we can even improve upon the likelihood of response that we saw earlier. Secondarily, if side effects are related to the microbiome, what we know is we have this operating model in which we have side effects that happen in T-cell rich organs and side effects that happen in T-cell poor organs. So for example, there are sterile organs such as the pancreas, the brain, the heart, which are not normally colonized by bacteria. And what we hypothesize is that the microbiome plays a critical role in determining the side effects in barrier or T-cell rich organs, particularly the lung, the colon, the skin, potentially the liver. And it suggests that there is a key role played by the gut microbiome, as shown in some of the earlier slides, in the development of the side effect. And if that is the case, and if people are developing side effects because they may have, for example, an altered gut microbiome, that stands to reason that we can alter that for therapeutic benefit. So we actually have developed a trial in which we are going to be giving patients this. And there's good proof of concept data for this. So in a early study, investigators at MD Anderson gave fecal transplants from healthy donors to patients with highly refractory side effects, in particular colitis. So steroid refractory as well as biologic vedolizumab and infliximab refractory colitis, a single fecal transplant, and they found that that made the symptoms better. So what we've done is we've gone to the next step. Instead of just treating 2 people, we want to treat a large national trial, potentially change the way people are going to be being treated with checkpoint inhibitor colitis. And in this intervention, people are going to be getting a healthy donor fecal transplant in a formal study in which that is going to be accruing nationally. And so this is EAZ 211, a national trial in which patients with checkpoint inhibitor refractory colitis that have failed all standard treatments will be getting a microbiome intervention. In the second phase of the study, if the early phase is meets some pre-specified boundaries of success, we'll be comparing the fecal transplant intervention to actually biologics. So the whole goal eventually of changing the way side effects are treated. Finally, what do we know about this? So as discussed in checkpoint inhibitor patients, it's clear that the microbiome is very important. It clearly mediates the likelihood of developing response. And we know that in the context of patients who are treated with monotherapy, PD-1, a third to half of patients fail in the first 6 to 12 months. And that's exactly when the microbiome might be most important, suggesting that when you have good bugs, the good bugs help the other factors that are important for the immune system to respond to checkpoint inhibitor immunotherapy to respond. And if you don't have those good bugs, while sometimes things work, sometimes they don't work, and an intervention might actually be beneficial. And as we've shown here, the intervention is beneficial. And there's parallel data from a separate group in Israel that showed something similar as well, suggesting that when you give somebody a transplant, you basically restore the balance that is needed to allow the body to respond to immunotherapy, that it's trying to do so, but it's prevented from doing so when people have adversarial bugs. There's clear data that we need to try to do more studies. Some companies have tried to develop specific consortium of bugs to try to essentially move this along and get a commercial pill. I will warn people that there's very limited overlap between the organisms that have been identified in the studies that us and other people have done, 1, and 2, between these microbiome-specific consortia that are being developed by commercial companies, suggesting that we have to learn to walk before we can run. It might mean that at least in the near term, we need fecal transplant-based interventions, but we will get there. Eventually, we'll get to consortium, but the consortium might need further refinement. And so finally, we also know that we want to do more in just melanoma, and so there's very good data that this is going to work in very promising data that this might be important in non-small cell lung cancer as well. And so we've got studies that are going to test that. And finally, we know how important side effects are. We are now curing cancer with advanced immunotherapy. We cure about a third of our patients with advanced melanoma with the first instance, and we now have relapse refractory interventions that are helping even patients with a disease that is no longer responsive to frontline immunotherapy. However, these patients develop side effects, and as we move the drug earlier into lines of therapy with treating patients in the preventative setting, patients with high-risk node-negative melanoma, with pembrolizumab's recent approval, more people are getting the drug and more people are going to get side effects. And as more people get side effects, the burden upon patients, upon systems, upon families is going to increase. And so what we now realize is that along with treating cancer, we need to focus our attention on treating cancer-associated side effects and mitigating the burden of cancer and side effects upon patients. And so we now have new microbiome interventions to treat these side effects. So what you can do as individuals, one, keep in mind that they are interventions. So if you have a side effect or if you have refractory cancer, we have studies for you. We also have studies for side effects, and these studies for side effects will soon be available, and it's any cancer and any checkpoint inhibitor can enroll in these studies. Some people always ask about fiber, about dietary interventions. I will warn people that dietary fads are, the norm. I have tried all kinds of different diets. There is some very provocative data recently published that ketogenic diets and high fiber diets might be helpful. I will caution people that the same people that talked about high fiber being beneficial also suggested that probiotics were not so beneficial. So keep in mind, before you start any kind of dietary intervention, please talk to your doctor. And there is this recent data from the MD Anderson group that was recently published in a good journal that high fiber was beneficial, and high fiber is 20 grams a day. So for anybody who's wondering what 20 grams a day of fiber is, it's 2 medium artichokes, 4 cups of broccoli, or 5 cups of Brussels sprouts. So again, it's no slouch. 2 artichokes, 4 cups of broccoli, or 5 cups of Brussels sprouts, uncooked. Now, the other thing that you guys can help us with is we would love to study this more. So we are already having a microbiome sampling effort. We will help you analyze this at no cost. We will pay for it. We will also analyze your dietary intake. So if you want to know whether or not your fiber intake is high, we have a research coordinator asking you these questions, and we will provide the analytic data to you for your own review purposes if you're so interested. And this study is open to, again, any checkpoint inhibitor treated patient at the Hillman Cancer Center. No matter where you are, who you're seeing, at any point in time, we can help you with this. So again, thank you for the opportunity to present, and I'll stop and take any questions if there are any.
Yes, Divakar, there are many questions in the box. And if you can read them, the first one talk about, is there a protocol for side effects? That's what you were just talking about, right? Can you let us know what type of side effects will be targeted by this protocol?
Yeah, sure. So what we are now doing is actually, I maybe answer the question a little bit more broadly. As I said, we're very interested in treating side effects. So actually, at the Cancer Center, there's an increasing focus on all kinds of immune-related adverse events, because again, the development of side effects really reflects the flip side of the response to cancer, because it essentially is an anti-self response. And so we actually have a formal clinic, and actually the co-leader of the program, Dr. Zora, is actually the dermatologist of this new side effect related effort. So if you have side effects, please let your physicians know. There's a clinic that is dedicated for this, and we are going to be seeing and measuring the impact of side effects upon patients. That's the clinical trial in question is specifically meant to treat colitis. So it's a national trial. It's being championed at the cooperative group level, and it's specifically meant for patients with colitis. So inflammation of the colon, typically about a third of patients about a fifth of patients were treated with PD-1 CTLA-4, but also about 10% of patients were treated with PD-1, right? So as we expand PD-1 early in the lines of therapy, more people are going to be getting colitis too, even though it's a relatively rare side effect. But okay, right now we have trials for that, yeah.
Another question in terms of, that's the central question that you try to address. How do you decide what organisms are in the fecal transplant?
Well, actually, this is a very interesting question for actually Dr. Zorov. So maybe I will let him answer this question.
Yeah, so as you underline, there are some discrepancy in the study published so far. So the study trying to correlate what was the microbial signature correlated to good outcome. So the concept was shown and proven in different studies. They really found the microbial signature present in patients in melanoma that correlate with or good outcome or bad outcome. So good microbial signature or bad microbial signature. The problem is this study, there was some discrepancy between the study, and there was not commonality, too much commonality between the study. And so you mentioned the recent publication we have made, right? And I think one major problem with this type of study is they are not large enough. You need to have, because of the microbiome is influenced by so many variables. So what you eat, what treatment you take, where you travel, the geography is also a critical factor. This type of question, trying to correlate the microbiome and the outcome, needs to include a large study from people living in different geographic location and so on. And that's exactly what we want to do. Dr. Abba talked about a banking protocol here, 20 or 19. That's what we're trying to do, to have not 50, 100, but several hundred, if not thousands of patients giving us a microbiome where we can sequence the microbiome and make this correlation, where we could take into account all the variables, the geography, the diet, the drug medication. I think this type of study will help us to really determine what is the best group of bugs that need to be given to patients to improve immunotherapy of cancer. Okay, I think we are done with the microbiome intervention, and thank you so much, Divakar. And can go to the next talk. It is a recorded talk by Dr. Najjar, who is another member of the melanoma program, and Yana is going to talk about the impact of the COVID pandemic in melanoma.
Hi, my name is Yana Najjar. I'm one of the melanoma medical oncology physicians here at the UPMC Hillman Cancer Center and the director of the Clinical and Translational Research Center. And I'll be speaking to you today about what I think is a very timely topic. So we'll be talking today about the impact of the COVID-19 pandemic on staging for patients with invasive melanoma. These are my disclosures, which do not impact my presentation today. The incidence of melanoma has unfortunately continued to steadily increase through the last several decades. It is the 5th most common cancer seen in the US in both men and women. And I like the graphic on the right-hand side because it shows you the kinetics of increased incidence over time. So you can see that in the 1980s, we were down here for men and women, and the slope has continued to go up quite steeply, and it continues to do so today. When we think about the incidence that's projected for 2022, we expect to see close to 100,000 new melanomas diagnosed this year and almost 8,000 deaths. Now, one thing to understand is that prognosis is fundamentally related to the stage at presentation. And what do we mean by that? So all of our patients recall us talking about the Breslau thickness. That's probably the first thing we talk about when we try and get a sense of how a patient is going to do long term. And what that is, as you can see over here on the left-hand side, it's a measure of how invasive the tumor is from its surface in the epidermis down to its deepest point. And there are several stages up to T4, and these directly feed into outcomes. Another thing I will say is that ulceration is also fundamentally linked to outcome. And ulceration is a pathologic feature, meaning when we look under the microscope, we see whether or not the epidermis or the skin surface overlying the tumor is intact. If it is, then the tumor is not ulcerated. And if it is, then the tumor is ulcerated. And we understand that ulceration is associated with a more aggressive phenotype of melanoma. And so what I want to show you over here is that for every T stage with increasing thickness, the survival probability goes down at 5 and 10 years. And I'll also draw your attention to the fact that with increased incidence of ulceration, that upticks a patient's prognosis, meaning if you have a thicker melanoma, your outcome is likely to be worse from historical data. And if you have an ulcerated melanoma, that is also associated with worse outcomes. And this is reflected in the HACC 8th edition of staging. Furthermore, the T stage, in addition to the presence or absence of melanoma metastases in the sentinel lymph node, feeds into the overall stage. So stage 1 and 2 are when a melanoma is limited to the skin. Stage 3 is when a melanoma has moved to a lymph node. And you can appreciate here in green, this is stage 3A all the way up to stage 3D. These are more heavily involved lymph nodes with or without the presence of what we call satellite lesions, meaning melanoma that's on the move within the skin. But the point I want to make to you here is that with increasing stage 3, the melanoma specific survival probability decreases, which is probably intuitive. Now, this is a study that I wanted to share with you coming out of the UK soon after the pandemic began. And this showed us that there was a significant increase in anticipated cancer-related deaths as a result of the COVID pandemic. And what they did was to pull almost 70,000 cases of various malignancies. They focused on the 4 subtypes that we see here: breast, colorectal, lung, and esophageal. And they performed some modeling to anticipate the outcomes, how the outcomes would be impacted by delays in care. And they modeled scenario A to scenario C. So these are their best case to worst case scenarios with an intermediate scenario B. And without getting into all of the details in the interest of time, I will draw your attention to the fact that there was a significant increase in the number of deaths at 5 years for every one of these malignancies, again, because of delays in care. They estimated up to 3,600 deaths within 5 years. And when you think about that in terms of years of life lost, which is how they conclude their paper, it's a pretty staggering number at over 63,000. We've also seen a decrease in melanoma diagnosis and in patients coming to attention from dermatology and medical oncology during the pandemic. So this is a study that came out of an Italian group, and there have been similar studies elsewhere. You can see that in the pre-pandemic era, 2.3 melanoma diagnoses were being made a day across dermatology clinics, whereas during and post-pandemic, perhaps I should say during the pandemic, since it's not yet over, we're at 0.6 melanoma diagnoses per day. And in the United States, dermatology practices have seen less patients. This has been widely published in the literature, and there is a decreased number of biopsies being performed. We wanted to address this issue head-on in our own practice, and so what we did was to perform a retrospective analysis in order to evaluate the impact of the COVID-19 pandemic at a large tertiary care center here at the UPMC Hillman Cancer Center. We evaluated 246 patients between March 11th, 2020, which was the beginning of the pandemic as announced by the WHO, with a data cutoff of January 12th of 2021. We then matched this cohort with 246 patients treated between March 1st, 2019 and March 10th, 2020. So we had 246 during COVID and 246 just prior. These are the patient characteristics. You can appreciate that in the pre and post-pandemic cohorts, they are well balanced for age, a median age of 65 for both. As is typical for melanoma, you see a higher incidence in men than in women. Again, balanced across the two arms. The majority of patients had self-identified as white, and there was very low numbers of Black or other races identified, which is something that we see because of where we are located geographically, but also because of the type of disease we're dealing with, which in this case is cutaneous melanoma. We did note that there were higher risk pathologic features noted post-pandemic compared to pre-pandemic. I'll draw your attention to the Breslau depth, which is where we began talking earlier about this being the most important factor, or rather the first factor that we look at when we start to stage and think about prognosis. And you can see that the median Breslau depth, the invasiveness of the melanoma, was 1.4 millimeters in the pre-pandemic versus 2.0 millimeters in the post-pandemic. And this was a statistically significant difference as well. We saw a trend towards increased ulceration in the post-pandemic cohort, though this did not reach statistical significance. But there was a numerically increased number of patients with ulcerated versus non-ulcerated melanoma. We also saw a significantly increased number of patients who had a higher mitotic rate, meaning more patients had more melanoma cells actively dividing under the microscope on their biopsy specimens in the post-pandemic than the pre-pandemic. The mitotic rate does not feed directly into the HACC 8th staging edition, which is what we use now. I think many of us anticipate that that will come back in the next iteration, but the point I'm trying to make is that mitotic rate is understood to be a poor prognostic factor if it's high, and we did see it go up in the post-pandemic cohorts. We saw trends towards increased perineural invasion and microsatellites in the post-pandemic cohort, but these did not reach statistical significance either. Now, this is where I think it gets really interesting and something all of us, I think my partners and I had all intuited just continuing to treat melanoma during the pandemic. We had the general sense that we were seeing less early stage melanoma. And when we actually looked at the numbers, that turned out to be true. So in the pre-pandemic era, of the 246 patients, 41%, 100 patients had stage 1 melanoma. Whereas in the post-pandemic cohort, only 29% or 70 patients had stage 1 melanoma, and that did reach statistical significance. So you can appreciate that if a patient is diagnosed with melanoma during COVID, they are less likely to have stage 1. And that's probably because they're coming to medical attention through dermatology and eventually coming to see us later than they would have otherwise been. We also saw that more patients were diagnosed with stage 3 melanoma during the COVID-19 pandemic. So 21% pre-pandemic had stage 3 disease, which typically means they have nodal involvement. Otherwise, they have satellite or in-transit lesions. Whereas in the post-pandemic cohort, 31%, 10% more had stage 3 disease. And again, you remember that stage 3 disease is associated with a significantly poorer prognosis in stage 1. And so these findings certainly have clinical implications. What about sentinel lymph node biopsies during the pandemic? So generally speaking, any patient with a melanoma that's 0.8 millimeters Breslau or more is recommended to undergo a sentinel lymph node biopsy in addition to their wide local excision. We found that most patients in the pre and post cohorts who were recommended a sentinel lymph node biopsy did undergo one. Sentinel lymph node biopsy was foregone in only 4 patients, and these were patients who either became ill with COVID, and by the time they came back to the OR, or by the time they got to the OR, it was decided that a long time had passed and to simply proceed with wide local, otherwise due to delays in scheduling, but that was only 1 patient. So you can appreciate that in spite of there being staffing issues and shortages, et cetera, which you're all very well aware of, we certainly continue to operate per standard of care, recommending and performing sentinel lymph node biopsies when appropriate. During the pandemic, 38% of patients who underwent a sentinel lymph node biopsy came back to have nodal involvement, versus in the post cohort, versus in the 38% of patients in the post cohort were found to have melanoma in the sentinel lymph node versus close to 30% in the pre cohort. So if you're undergoing a sentinel lymph node biopsy during the pandemic, you are more likely to have sentinel lymph node involvement. And that is why you see a higher number of stage 3 patients, as I had shown you a couple of slides ago. It's because of these more likely involved lymph nodes during sentinel lymph node biopsy that you see an uptick in the diagnosis of stage 3 melanoma. What about with metastatic disease? We did not find a significant difference in the number of patients with a new diagnosis of stage 4 disease in each arm. However, we found a significant increase in patients who are presenting with metastatic recurrence in the post cohort compared to the pre cohort. So 7.7% of patients in the pre cohort had a metastatic recurrence, 7.7% of patients in the post cohort had a metastatic recurrence versus 3.3 in the pre-cohort. And interestingly, for patients with metastatic recurrence, the median time to recurrence from the time of initial melanoma diagnosis more than doubled in the post cohort, so 25.5 months to 60 months. While this did not reach statistical significance, I would argue that it is clinically significant. And some of the statistics here are driven by the smaller numbers that you have. So we have more numbers of patients in stage 1, 2, 3 versus stage 4. And I think that's why we're not seeing statistically significant numbers, though we think some of these are clinically significant, as I mentioned. Furthermore, we found that 6.5% of patients in the post-pandemic had brain metastases, compared to 1.6% of patients in the pre-pandemic. This, I think, is a very concerning finding because brain metastases are well understood to very unfortunately be a terrible prognostic marker in terms of how our patients do long-term. Now, fortunately, we're in the era of very active immunotherapy, but historically, this has been a real problem. And so the fact that you're seeing a jump from 1.6 to 6.5% brain mets is really very concerning. What about trends in treatment? So at our institution, patients undergoing adjuvant therapy were more likely to receive targeted therapy than they were to receive immune checkpoint inhibition in the pandemic era. Now, what I mean by adjuvant therapy is when tumor is resected and we're treating for a year to try and decrease the likelihood of metastatic or local regional recurrence. Targeted therapy is taken orally. These are pills patients take twice a day, every day. Whereas immune checkpoint inhibitors are IV treatments. Patients come in and they get an IV and they're in the treatment area. It's a lot more healthcare interfacing from the patient's side. And so I think you can see here that our appetite for bringing in patients really was decreased during the pandemic. If we could spare patients trips to the treatment room, we really tried to. And so we saw more targeted therapy during the pandemic than we otherwise saw compared to adjuvant therapy. We did not see the same difference in metastatic therapy. And I think that's due to two things. I think when a patient has metastatic disease, we tend to favor treatment with upfront immunotherapy, and that has really been the case for some time. Most recent data has really convinced us that this is the way to go. But I also think in the metastatic setting, we are more apt to do what we think we have to do, and we're less likely to make any sort of compromises. Not to say that targeted therapy in the adjuvant setting is a compromise, but it's to say that if we could spare patients the trip in the adjuvant setting, we did, whereas in the metastatic setting, I think we just get on with it and do what we think we have to do. So in conclusion, these data highlight the importance of continued routine total body skin exams for early detection of melanoma. Delays in care are associated with higher stage melanoma, as I have shown you, and alarmingly, more brain metastases. We did not reach the median progression-free or overall survival. We don't yet have that follow-up time, but I have no doubt that when we come back and look, we will see a higher incidence of death related to melanoma during the pandemic compared to before, even accounting for changes in therapy. Timely oncology referral for patients with melanoma remains critical even during the pandemic. And with that, I thank you for your attention. I'm sorry I'm not there in person, but please don't hesitate to reach out to me if you have any questions whatsoever. I would like to thank our patients and their families. This study is an excellent example of how we use our 9699 tissue and biobanking protocol. It also allows us to look at long-term outcomes. My melanoma team and Sabah Sheikh, who is one of our excellent fellows who really spearheaded the collection and analysis of data for this project. Thank you.
Okay, great. So this was a recorded talk. For the interest of time, I see no questions, so we're going to move on to the next talk. So Brittany Sinavi is going to talk about pediatric melanoma. So Brittany, it's up to you.
Thank you. Okay. Good morning, everyone. Thank you for having me today. Today, I'm going to talk a little bit about pediatric melanoma and how it differs from adult melanoma. For background, I am a pediatric oncologist, and so I take care of children with all forms of cancer, but specialize in patients, young patients with melanoma and skin cancer. So the first question I always get, that I'm always asked is, do children get melanoma? And the answer is, of course, yes, because I'm here speaking to you about it today. But I think reviewing some of the statistics about pediatric melanoma will help understand why many people don't know that this is something that children can get. And so for new cases of melanoma estimated in the year of 2021, there will be about 106,000 cases. The percent of new melanoma cases by different age groups, so in 0 to 20 years of age, that'll make up less than 1% of all cases of melanoma, accounting for about 420 cases. When we move into the older age bracket of 20 to 34 years of age, that'll make up about 5% of cases, accounting for about 5,000 cases. And just, I should take a step back and define this AYA term. So in pediatric oncology, we often take care of adolescents and up into the young adult age group. And the age bracket of 15 to 39 years of age is often termed the adolescent and young adult age group. So I'll be referring to that age bracket a lot with my pediatric cohort. So to compare these numbers for new cases of all types of cancer that we see in children 0 to 14 years of age, we'll see about 10,500 cases. So you can see a lot fewer cases of all cases of pediatric cancer compared to all cases of melanoma alone. And then when we move into the older age bracket of 15 to 39 years of age, those AYAs, there'll be about 88,000 new cases of cancer each year in 2021. So I always say it's a drop in the bucket. And for that reason, it's been overlooked for some time in the pediatric, in terms of pediatric melanoma and where it stands in the melanoma world as a whole. But despite this, it is the most common type of skin cancer in children that we see. So one of the things that as a pediatrician, I was taught early and is one of the mantras of pediatrics is that children are not little adults. And so although children may get melanoma, as adults do as well, we know that we can't just assume that everything can be done to them that we do to adults. Diseases may manifest differently, as I'm talking about here today. Their bodies and their minds are developing and growing. And so we have to take that in consideration with all therapies and treatments that we prescribe for them. Their bodies work differently. There's different physiology. They're dependent on others for their care. They need someone to recognize something is abnormal on them, to bring them to see us, and to even perform any activity that they need to live every day in their life. And then importantly, they tolerate medications and treatments differently. Sometimes that means they may tolerate them better, and sometimes that might mean that they tolerate them worse. And really importantly, they have a much longer life expectancy. So it's becoming increasingly more prevalent in the literature to see pediatric melanoma being discussed, and for that reason, I'm so glad. So first of all, how are they similar? Pediatric and adult melanoma? Well, a biopsy is always needed for diagnosis. The staging system is the same. Most patients will have localized disease at diagnosis. The prognosis is completely dependent on stage. 90% are expected to be alive at 5 years after diagnosis. And then the treatment guidelines, for the most part, are the same. And I'll get to that a little bit more later. For the risk factors, those are also the same in a lot of cases. So fair skin, light colored eyes, red or blonde hair, those that have poor tanning ability, excessive exposure to UV sunlight, increased numbers of common or benign moles, history of dysplastic nevi, and then a family history of melanoma, all very important in the risk factors for pediatric melanoma. And now for the differences. And here I feature a photo of one of my fellow oncologists at the Children's Hospital of Pittsburgh, and one of our cancer patients who adores him and dressed up like him at Halloween. And you can see, despite to the best of his effort to look exactly like him, he's still different, just like pediatric melanoma is different from adults. So first, terminology and classification is the most challenging. This is the most challenging when I see a new patient. If a child has had a biopsy and the diagnosis comes back melanoma, in some ways that makes it a little bit easier to come up with a treatment plan. But in a lot of cases, given their age, the diagnosis of melanoma won't be given, and there'll be a lot of other terms on the pathology report. Atypical melanocytic tumor, atypical melanocytic tumor of uncertain malignant potential, atypical melanocytic proliferation, and so on and so forth. And a lot of times we have to use this descriptive terminology and all of the information in front of us, including the presentation of the lesion itself and how the child is doing overall, to make a decision about their treatment moving forward. Also, how we classify melanoma, even when we get a diagnosis of straightforward melanoma, is a little bit different in the pediatric world. So we'll often refer to 3 different types of melanoma. One being conventional or, quote, adult type melanoma. The second being Spitz melanoma, which I'll elaborate on in the next slide. And then the third being melanoma arising within a congenital melanocytic nevus. So a little bit about Spitz melanoma. Dr. Sophie Spitz was an American pathologist who discovered in 1948 what she termed juvenile melanoma, or children that were having biopsies of skin lesions for which underneath a microscope appeared a lot like melanoma, but overall seemed to be having better outcomes than most adults do with melanoma. And from this, we've used her name and linked it to melanoma in pediatric melanoma moving forward. There are benign moles that are called Spitz nevus, for which I often don't see the patients, but our dermatology colleagues do. And then there are a very puzzling group of tumors called atypical Spitz tumor, in which we have to work to decide whether or not it is melanoma or an atypical mole. And then last, Spitz melanoma. And so this, we really get into the challenges of a rare disease. Here we are, most people don't even know pediatric melanoma exists. And so when a child presents to a doctor with a new skin lesion, there's often delays in diagnosis associated with a low index of suspicion, an atypical presentation, which I'll also discuss, and then a difficulty identifying that atypical nevus or abnormal mole from a true melanoma. And so just a little bit more about the low index of suspicion and the atypical presentation in children. So most people will be familiar with this. It is as the clinical acronym that we use to detect an abnormal mole that may signify melanoma, or the ABCDEs of melanoma. So, and these apply to children too, but as I'll talk about next, this isn't how we always detect an abnormal skin lesion in a child. So A is for asymmetry, B for uneven borders, C for color variation, D for diameter greater than 6 millimeters, and then E for evolving, meaning any mole that's changing, bleeding, itching, crusting, or in other words, is the ugly duckling. Interestingly, in pediatric melanoma, those same ABCDEs don't always help us to identify a lesion on a child that needs to have a biopsy. So there was a study of 70 patients, 0 to 19 years of age, from the 80s to 2009. And in 60% of the patients in the 0 to 10-year-old age group and 40% of the patients in the 11 to 19-year age group, they did not present with these conventional ABCDE criteria. So how do they present? Well, often they present with a smooth red bump on their skin. And this other ABCD criteria was developed by those researchers to help pediatric providers know when to suspect an abnormal lesion on a child. So the A here stands for amelanosis, meaning that you cannot see the brown or black pigmentation. B is for bleeding or a bump. C is for uniform color as opposed to varied color. And then D is for variable diameter, meaning the size really doesn't matter. Even a small red bump on a child could be the first presentation of a melanoma. And oftentimes, these are de novo, meaning they did not have a pre-existing mole. They never had a lesion there, and it kind of popped out of nowhere, which is the story that most parents will tell me about their child's melanoma. So the diagnosis, reaching that diagnosis is different in pediatrics. And accurate diagnosis, especially in the Spitz category that I had discussed earlier, is incredibly challenging. The morphological assessment, meaning what it looks like under the microscope, alone has limitations. And we know that there's often expert disagreement. If similar experts both look at the same lesion, they might arrive at a different diagnosis, which is a real problem for us trying to develop a treatment plan for the patient. And then importantly, integrating genomic analysis. So what are the genetic changes of the melanoma or the tumor itself, and the evaluation of a pediatric melanocytic tumor can optimize the diagnostic accuracy and provide important prognostic information for the treating physician, such as myself. But I talk about this with all families. There's not one molecular marker in a tumor. There's yet to be that holy grail that will identify which child with pediatric melanoma will have a poor outcome and which children with pediatric melanoma will do just fine regardless of our treatment strategies. And then interestingly, children and adolescents often present with thicker primary tumors than do adults. So they have more advanced T-stage by classification, and they'll more frequently have disease spread to their lymph nodes at the time of sentinel lymph node biopsy. But despite this, despite these thicker primary tumors and the high rate of node positivity, the outcomes appear to be better for younger patients. And why is the million-dollar question? We still do not know this. Treatment. So as I discussed before, most treatment is per adult guidelines. The wide excision that needs to be performed on a primary melanoma is, we follow the same adult guidelines in terms of the size of that excision, though there are unique considerations based on the child's size and their future for growth and development. As you can imagine, doing a large surgery on a 2-year-old is quite challenging, as their overall body is so much smaller compared to an adult. There is a debate whether or not sentinel lymph node biopsy is as useful in the Spitzoid category of lesions, which is often a detailed discussion with the family before proceeding with that next step. Completion lymph node dissection, the utility of that has never been studied in pediatric melanoma. We do follow the same adult guidelines, though I do note a much, much lower rate of complications from completion lymph node dissections in children compared to adults. And then systemic therapy for children, there's been no efficacy trials studied on pediatric patients for melanoma specifically. And oftentimes we do follow the robust adult data and use dosing guidelines based off of the adult guidelines and reports of how children have tolerated those drugs in other pediatric cancers. And with that, I'll leave you with our melanoma program. We are available through the Hillman and the Children's Hospital of Pittsburgh website. Lauren, who you heard from earlier today, takes in all referrals, and we're really happy to see any child with a melanocytic tumor, whether or not it's melanoma or it might be melanoma, or there's any worry for that, to help sort through this difficult diagnosis and come up with the best treatment plan. And again, it takes a village to take care of these patients. really thank all of the support from patients and families like yourself in providing care for these patients. In the future is bright with research and collaboration. And I really hope that in speaking to you all and speaking to other groups of providers and individuals, that we can improve the recognition, diagnosis, prognostication, disease understanding, and treatment options for children with melanoma to ultimately improve their outcomes. And with that, I'll thank you. And take any questions.
Thank you so much, Brittany, for this great presentation. It's always a very stressful thing, right, to have to face a pediatric melanoma, very difficult diagnosis very often, right? That's where maybe teamwork is very important, bringing together the oncologists, the pathologists, and so on. I don't think we have any question for you, but if anybody has any question, please, you can maybe write in the box or contact Dr. Brittany Sinave to get answer. So we're going to move on now to the next talk about integrative oncology at the Hillman Cancer Center. And this presentation is going to be given by Dr. Lainey Francis.
Hi. Let's see. I'm just sharing my screen. Okay. Well, that's weird. I'm like popping up in the corner of my screen looking like an avatar. That's weird. Hi, everyone. Thanks for having me talk. I think this is the last part of the symposium today, and I'll give you a second to just take a deep breath. You heard a lot of information and from a lot of experts about a lot of interesting and complicated and probably overwhelming topics. So this will be just something to sort of watch and listen, nothing to really worry about or take in or take notes on. I am a medical oncologist at the Hillman Cancer Center in Shadyside, and I run our Wellness and Integrative Oncology program. And that is a program with a lot of components, which I'll highlight some of today. It is a space as well as various programs, different ways to interface with medical providers and integrative therapists, all focused on managing symptoms and quality of life for patients with cancer. So this first shot of my slide presentation is a view of our wellness suite and studios, which is on the third floor of the Hillman Cancer Center. It is a brand new space that officially opened a little less than a year ago. And it's about 3,500 square feet of clinic rooms and also various spaces, all focused on our wellness and integrative oncology program. So this gives you at a glance an idea of what we're doing in the wellness suite and studios. I want to focus for most of the talk on our integrative oncology consults. That's something that may apply to many of you as patients with melanoma and maybe of interest to many of you as caregivers and loved ones of people with melanoma, whether that's active melanoma on treatment or survivors, or even people with strong desires for prevention. And in the integrative oncology consults, myself and my nurse practitioner, we see patients in sort of a very pleasant, non-medical setting to talk about your cancer, your symptoms, and lifestyle and integrative goals. That might be in regards to diet, it may be in regards to exercise, it may be in regards to stress reduction through mindfulness, it may be in regards to symptom modulation with or without other pharmaceuticals in terms of things like acupuncture or yoga or medical cannabis. It's a very patient-centered approach where you have time to really talk, and we are there to problem solve and advocate for you. We have a dietitian who is focused on a more holistic approach as well as a more personalized and collaborative approach. And we will, after the consult, sometimes connect you with the dietitian. We have a yoga and meditation practitioner. We have an acupuncturist, and you'll see reflected in the rest of the weekly schedule that all of these are available for you as you enter our program after an integrative oncology consult. And again, very focused on you, your time, and your resources. Our nutrition program is really exciting. We have a beautiful state-of-the-art teaching kitchen. And in addition to a very personalized approach to meeting one-on-one with our lifestyle dietitian, we also have streaming classes, cooking with cancer classes that are question and answer, very interactive and focused on things like getting more protein in your diet, how to snack when your appetite is low, taste changes associated with cancer. And also these cooking classes, as well as your interaction with our dietitian, can focus on questions you may have about sugar, keto, intermittent fasting, even some of the big question mark black box questions around supplements and probiotics, which you've heard a lot about, things like that today. But how can you as a person in real time be thoughtful and safe about what you're putting in your body? I work really hard with my colleagues, Dr. Dwalker, Dr. Najjar, to make sure that what you're doing is safe and they're aware of it, that we're working with PharmDs and clinical trial specialists if you have questions. So please don't be afraid to come and talk to me about what you're interested in, what supplements you're thinking about, what your daughter-in-law or brother or friend in California told you have to take. We are there to be safe, supervised, non-judgmental, and also open-minded. So that's a little snapshot of what we are up to in the Wellness Suite and Studios. We have a large and growing team. As you can imagine, this area of oncology is extremely popular and growing, and we are set up to be very helpful and make your experience very streamlined. We have myself, a nurse practitioner, a collaborative nurse, a project manager who works on some of our research and partnerships and quality improvement. We have a coordinator who schedules. We have our dietitian. We have an acupuncturist. We have a yoga therapist. So all these people are there to help make this program work. We think a lot about the stress of cancer, the stress of this pandemic, and how to be a sort of sanctuary for thoughtful and kind behavior within our cancer center. So I think of our Wellness Suite and Studios as something of a refuge. Not to sound hooky or wah-wah, we do think about energy and responsibility and kindness, and we really live by that responsibility. So this is a shot of one of the message boards in our space, because we really do ask you to take responsibility for the energy you bring into our space. We believe your words matter, your behaviors matter, our patients and our staff matter, as do you. I mentioned our nutrition program, which again is growing, but I did want to alert you to our Cooking for Cancer classes. They are only on Wednesdays now to streamline that. They're at 9 o'clock. This is the Zoom link and anyone can join. If you want to take a minute and snapshot this slide for your records, these are lovely. Our project manager and dietitian cook a different dish each Wednesday. They tell you how to do it. They talk to you about different tips within that. And it can become a really helpful community for people that are trying to think about how to eat with cancer, after cancer, during cancer, as well as for caregivers that want to be a part of participating and find a way to have some control in this disease and in cancer in general. Well, sometimes it feels like we have no control. We also similarly have Movement for Cancer classes, which are also available to join. These are run by our meditation and yoga practitioner. She's also, as a part of our program, able to see people one-on-one to talk about What is yoga? What is breath work? What is mindfulness? That service is accessible after you see me or Kayla, my nurse practitioner, in consultation. This background snapshot is our yoga and movement studio, also on the 3rd floor, a beautiful sun-filled space where we teach yoga one-on-one and in groups, and are continuing to expand this program. So finally, again, it's not showing up very well, but if you snap a picture, this is our website. It's hillman.upmc.com/cancercare/integrative/oncology. This is our phone number to make an appointment. You don't need to be referred. You can call and make an appointment no matter who you are or what you are. A typical copay may apply. Services, when recommended, are sort of curated to you and your symptoms. Patients that are interested can get 3 demonstrations or complimentary sessions to try things like acupuncture or yoga. We fundraise for that, so everyone can try these to determine if they're worth their time or effort. If people want to continue with acupuncture or yoga, then there's a fee for service. The way our program is structured, we do collect the fee for service at the time of the visit. If your insurance company will reimburse you on the back end, or if you have a health spending account, that's ways, and we are there to navigate and help you with this process. But everything is there for you to try and get involved in without significant cost. So I hope that is a nice way to end. Again, we're here for management of symptoms, management of quality of life. I am a medical oncologist in touch with and aware of the complicated treatments that you are on or considering. We are a place for advocacy as well as sharing space, there to help and be a way to meet you halfway in a very patient-centered approach. So I'll stop now. I thank you very much for your time and for allowing me to be a part of this. Thanks to the organizers as well. And take care.
Thank you very much, Annie, for this very informative presentation. And I would like to thank also all the speakers for their great presentation. I hope it was very helpful for everybody who attended this meeting. John, I'll lend you the next step.
Yeah, no, similarly, I want to thank everyone who's participated, the patients who've remained, 80 to 100 folks who joined today, and to hope that we're back face-to-face in 2023. I want to thank in particular Lisa Huntley, who took the lion's share of the work in organizing this today, and turn it back to Heather from AIM to give us our closing comment.
All right, thank you so much again to all our presenters, for everyone who joined us today. For those of you who missed the beginning, I am the Director of Community Engagement with AIM at Melanoma. I'm just going to ask for like 2 minutes for those of you who are still here to tell you a little bit about what we have going on at AIM. And we'd love for you to join us for any of our programs. And just again, thank you to UPMC for hosting today, and Lisa Huntley for all the work that you put into this. So at AIM, what we strive to do is provide relevant and reliable information, and you'll find that on our website. And I just want to highlight just a few programs that we have. You heard from Melissa earlier. She's doing a wonderful video series with us right now called Melanoma 101, where she's covering the basics. So if you want to know how a mole forms or what a biopsy entails, all of that, head on over to our YouTube channel and you can watch Melissa's very informative videos there. The other exciting thing that we started this year is a podcast, our Beyond the Clinic podcast, Surviving and Thriving with Melanoma. It tackles those psychosocial topics that you might not necessarily have time to cover while you're in the clinic. So we've released 3 episodes so far this year on social media, immunotherapy and caregiving, hereditary risk, but we have a lot of great programs coming up. So you can find our podcast on our website, on Apple Podcasts, Spotify, all the places. These are quick 30-minute conversations. We envision, listening while you're in the car, or while you're in clinic on some of these great topics to kind of help you get through your treatment or even if you're a caregiver. And then all the resources that we have available on our website are really for patients and their families. So you can find some symptom and side effect management guides, library of videos from our past symposiums and events, as well as a place to share survivor stories or to read from others. Everyone is invited to submit there. You can search for clinical trials, or you can join our peer-to-peer support program, which is a wonderful opportunity to connect with others who might have a similar stage in diagnosis as you, just to talk to someone who understands. We also have lots of organizations. Our Steps Against Melanoma walks. I know that Pittsburgh's walk is coming up in May, so you can join them in person there. We do have about 20 others across the country this year. And then obviously, we're always looking for those who want to give back and contribute as a volunteer. You can contact me for that, or if you have medical questions, you can reach out for our Ask a Medical Expert and we'll put you in touch with Melissa. So if you need to reach anyone at AIM, you can go through me. It's heather@aimmelanoma.org, and I'd be happy to answer any of your questions or refer you to resources, help you find, past videos, anything that is relevant to what's going to help you along your journey with melanoma. So thank you for allowing me just a few minutes to share that information on behalf of AIM. And again, thank you to our organizers and to this wonderful group of presenters and such informative information this morning. Thank you to everyone who kind of sat with us all morning. These videos will be available on AIM's website as well as on YouTube once we get them edited down. So thank you again. And Dr. Kirkwood, I don't know if you have anything else you want to add, or we can just wish everyone a great day.
Yeah, we thank everyone for their perseverance, and I think we look forward to seeing all of our local supporters at the AIM at Melanoma Melanoma Center Walk Against Melanoma in May, and until next year.
All right.